Okay, a very good afternoon to one and all present here, and thank you for joining us for this pre-conference workshop of AOG of the annual AOGD conference. The topic is CTG Basics to Advance. Distinguished faculty, dear colleagues and delegates, it's a great honor to welcome all of you for this pre-conference workshop on CTG Basics to Advance. Encouragement, enthusiasm, and excellency are the hallmark of our department at the Hamdard Institute of Medical Sciences and Research. With these words, it is my pleasure to invite Dr. Reva Tripathi, Head of the Department of Option Gynae at Hamdard Institute of Medical Sciences and Research, to deliver the welcome note. Ma'am needs no introduction. She is an excellent teacher, a clinician par excellence. At present, she is heading our department at HIMSA. Formerly, she was Dean and head of the department at Maulana Azad Medical College. She was facilitated with Professor D. Kutty Annual Lifetime Achievement Award by Foxy, and she has numerous publications in national and international journals to her credit. Ma'am.
Dr. Reva, ma'am, you have to unmute yourself.
Okay, am I audible now?
Yes, ma'am.
Okay, so thank you, Sumedha. So my first duty is to thank the AOGD office bearers, Dr. Mala in particular. Where is Dr. Mala? Can we see Dr. Mala?
Yes, ma'am, we can see.
Have you joined, Dr. Mala?
Yes, ma'am.
Okay, anyway, so thank you to the AOGD office bearers for permitting us to hold this workshop, and also thanks to our local management who permitted us to do it also. And somehow due to their preoccupation, they haven't been able to join, but nevertheless, we will go ahead. And I would like to welcome all the delegates, because obviously no workshop is worth the name until the delegates are present. Now, the topic for today is cardiotocography. Obviously, everybody knows that this is not a new topic, but despite the fact that it's decades old, it needs reinforcement for the senior people, and it needs to be learned and relearned by all the juniors. So, because there's always some issue about a lack of clarity. So, therefore, I think it would be worth everybody's while to go through for some hours on cardiotocography. We have tried to make a very broad program, and you will get insights into the basics as well as the recent advances in the cardiotocography. So I hope you will enjoy this workshop, and you will have some good takeaways by the time it is finished. So thank you very much. And I would request, thank Dr. Mala to be present, and I will request her to say a couple of words, please.
Thanks, madam. Good afternoon, everyone. Committee of 42nd Annual Conference of AOGD and first e-conference, it is my privilege to be a part of this workshop on CTG Basics to Advanced, organized by Dr. Reva Tripathi, Dr. Aruna Nigam, together with her team, Dr. Neha Gupta, Dr. Arifa Anwar, Dr. Sumedha Sharma, Dr. Arpita Dey, and Dr. Nidhi Gupta. The program is crafted in such a way that at the end of the day, we will learn everything about CTG, which is going to be very helpful in our day-to-day practice. I'm sure all the postgraduate students, residents, and young buddy delegates will immensely benefit from today's e-conclave. I wish all success to today's workshop, and I hand over the scientific program proceedings to Madam Dr. Reva Tripathi to carry on with the scientific deliberations. Over to you, Madam.
Ma'am, you are...
Yeah, I've unmuted myself. So thank you, Dr. Mala, for being very kind to us. And we will be starting with, I will start with a small overview. A lot of the details will be taken care of later during the course of the deliberations, please, can I have my slides, please? So this CTG has got a very long history because initially when people started to hear the fetal hearts, then it was manually by putting their ears close to the maternal abdomen to listen. And from that primitive kind of technology, we have moved so many decades further ahead up till the time that now we have so many new advances of the computerized and other types of CTGs. So, you know, this is the old thing about how, you know, everybody of you have seen the Pinard stethoscope and the Dopplers. And now, of course, we have the CTG. And you're possibly, a lot of us are familiar with the top diagram, the top picture, as well as the bottom. Maybe many of the youngsters are not. But that is the way that things used to be done and are probably still being done in many parts of the world. So there are many types of CTGs. They could do antepartum, intrapartum, you can do intermittent, continuous. Now, what are you seeing in the CTG? It's either a fetal heart rate recording or it's a fetal ECG. You can do it external, you can do internal, you have the conventional versions, you have computerized versions, and paper speed could be 1 centimeter a minute or 3 centimeters a minute. Now, the important thing for the youngsters to understand is that all these issues are not mutually exclusive. So you could have a variety of these combinations and you have to figure out exactly what you're doing before you're able to read it. Now, starting with an NST, it's one of the commonest investigations that we are doing these days for antenatal patients, but how accurate is it? So the literature tells us that there is no great significant difference in the risk of perinatal mortality and morbidity rates, which it was used to predict. So the point is that should we do it or should we not? So there are many agencies who recommend that its use should be rationalized and it should not be done for all and sundry, but yes, for some high-risk patients, it is an important thing. Another point that you will repeatedly be hearing during the entire duration of this workshop is that CTG interpretation requires not only knowledge about interpreting the graph, but you need to have the entire clinical picture in front of you. You need to have various details about dating and how growth has gone and other things, because all these parameters are likely to change the reading that you are having. Now, NST, for all the amount that we do it, that there is a statement that says that given that an abnormal test, a fetus is more likely to be healthy than compromised, results must be used cautiously by clinicians, particularly at early gestational ages when delivery could result in significant morbidity. So there you see that gestational age is important, plus the interpretation. So don't label fetuses as abnormal so quickly. Now, what about the scene for intrapartum CTGs? So the Cochrane review of 2017 on cardiotocography says that CTG during labor is associated with reduced rates of neonatal seizures, but no clear differences in cerebral palsy, infant mortality, or other standard measures of neonatal well-being. This is an important thing to keep in mind, considering that all of us are so determined to have an CTG facility available with us in our labor room. And in case it is not available, then we feel that we can't deliver proper intrapartum care. The indications for continuous CTG monitoring, etc. This is an overview. This will all be done later. It will be included. You have intrapartum indications, antepartum indications, fetal problems. Another important issue that I wish to flag is who should read the CTG. Is it only obstetricians? Is it only the consultants, the residents? The point that I wish to emphasize is that anybody who is taking care of a laboring patient should be able to read a CTG, which includes midwives and nurses also. Now, this is something that we need to get a little more open about, and we need to include them in our management strategies. This will obviously require regular training, workshops, evaluation, and feedback. If you don't have that, then actually having learned it once during residency isn't really quite enough to do the interpretation. Because the problem with CTGs are that there are huge amount of inter-observer and as well as intra-observer differences in subsequent evaluations. So all this must be kept in mind. And there are various classification systems. It's better to use one particular classification system and all the people in that labor room use the same classification system so that everybody is on the same page. Now you look at this data, which is from the UK, which says that faulty CTG interpretation was the cause for 62% of perinatal problems in this study of each baby counts. Now, if you look at this kind of data, then you realize how much is the importance of the CTGs. You have a reinforcement, you learn something new. Again, these important points to keep in mind, they will be repeated. You may think that it's being repeated ad nauseum, but I think the important issue is to know and to be very clear that these things matter and the entire history must be known for an accurate interpretation. Now, what are the newer developments? One is computerization, one is mobile technology, artificial intelligence, and possibly by the time a lot of the youngsters grow up, there will be other things which we can't even imagine today. So, well, if the manual CTG has got so many errors, then is computerization the answer? Well, the computerization calculates short-term variability. It does reduce the inter-observer variability, and it was used in part of the truffle trial of 2013. But there have been studies which have included the computerized CTG later. This was a large study published in the Lancet in 2017, including more than 3 maternity centers in Britain. And the final conclusion was that the computer analysis did not really reduce the incidence of substandard care. Now, the substandard care is obviously not a large problem, especially in a place like Britain. So the rates of the stillbirths are low, and they're more than, I mean, they're much less than what the original Dublin trial was for the CTG in way back in 1985. But despite those numbers, there's a high level of care, but the adverse outcomes did occur. And the main issue was that the failure of interpretation. So therefore, the computerization doesn't really have a complete answer as on date. Now, because the computerization of the conventional CTG does not have an answer, so therefore people have tried to do use fetal ECGs. Now, the earlier fetal ECGs required internal monitoring. Now, to overcome the problems of internal monitoring, people started to use this device, which is called the Monica device, which places 5 electrodes on the maternal abdomen to detect fetal ECG. But the problem about the noise of the maternal ECG being overcome have been done to some extent. But what does the evidence say? Despite all the newer inventions and other issues, CTG and the Monica and outcomes. So required. We started Doppler transducers, telephone lines, and it was comfortable for the patient, but we didn't really get any results worth talking about. And then we started to use the local thing about the WhatsApp, which I'm sure that all of you know about much more than me. So it's our own telemedicine system. You take a screenshot and you send it to your consultant who gives you some feedback. But don't forget that the biggest shortcoming of this is that it is only a very short strip that is being shown. And you are making your decision on short strips. So that is going to be a problem. So now what's next? Artificial intelligence. That's the latest buzzword, everybody knows. So now there have been studies which are using the application of artificial intelligence to interpret CTGs. They haven't really got their complete answers as yet, and this is a new and evolving topic. Let us see over the next couple of years, they might be able to show that the artificial intelligence is smarter than the individual intelligence. Well, let us see. So in conclusion, I only want to say that despite various advances, continuous CTG, computerized CTG, the last word on CTG has yet to be said. And I think we'll continue to be in this state till everything is cordless, just like this cartoon says, even the baby is cordless. Until that time, CTG, our friend, or whichever way you want to look at it. But nevertheless, as of now, CTG is important, and I will request you to please follow the subsequent lectures carefully so that you have a good idea about CTG by the end of the workshop. Thank you very much.
Thank you, ma'am, for this nice overview of CTG. Now the next speaker is Dr. Shaili Arora. She is a consultant obstetrician practicing in West Delhi. She is a member of the Royal College of Obstetricians and Gynecologists, and she is regularly involved in conducting various MRCOG classes. Her topic today is physiology of acid-base balance. Dr. Shaili.
I'll share my view. Thanks for the introduction, ma'am. First of all, I would like to thank AOGD and the whole organizing team to help me invite me and speak on this platform. The topic for me is physiology of acid-base balance. This is a complete basics to CTG, I would say. So now everyone must be thinking, why physiology? Why is it important? Then we all know the fetal heart rate pattern actually reflects the oxygen status of the fetal brain. The CTG can be used as a window to see the oxygenation status of the fetal brain. So whenever there is any change in the oxygen level, it produces a recognizable pattern in the fetal heart rate that can be easily detected. So understanding this physiology could be the key to appropriate interpretation of CTG and finally, and thereby intrapartum management. So I will be covering in this next 10 minutes that what regulates this fetal heart rate, what are the physiological fetal adaptations to stress and hypoxia, which are reflected on CTG, and what are the pathological changes, which we can see it on CTG. So what control fetal heart rate? Fetal heart rate is controlled by, as everyone knows, autonomic and somatic component of central nervous system, including and involving the chemoreceptors and baroreceptors. Autonomic means everyone knows sympathetic and parasympathetic. Sympathetic increases the heart rate, parasympathetic decreases the heart rate. So as the pregnancy advances, the parasympathetic matures and thereby our baseline fetal heart rate declines and stabilizes to less than 160 beats per minute. There is a constant fluctuation between sympathetic and parasympathetic, which creates that wiggliness of this baseline of fetal heart rate, which we observe as variability in fetal heart rate on CTG. Now the somatic nervous system, which is responsible for the voluntary control of the body movements via skeletal muscles, it accounts for acceleration. So the presence of acceleration is a hallmark of healthy or a non-hypoxic fetus. We can very well be sure that this fetus is healthy because it has got sufficient glucose and oxygen level to spend its energy and on non-essential somatic activities. So coming to chemoreceptors and baroreceptors, which play a great role in modulating your fetal heart rate. The peripheral chemoreceptors and baroreceptors are located on aortic arch and carotids. Chemoreceptor central one is located at brainstem. Chemoreceptors, which by name itself says that they react to chemical, that means oxygen levels, carbon dioxide levels, hydrogen levels, that is the pH or acidotic or alkaline. So whenever there is a decrease in oxygen level, it causes vasoconstriction. When there is increase in carbon dioxide or acidotic babies, it increases the sympathetic output, which causes tachycardia and hypertension. Baroreceptors, by its name itself, means pressure. That means it responds to arterial pressure. So whenever there is increase in arterial pressure, it stimulates the vagal nerve, which causes bradycardia and vasodilatation. These baroreceptors decelerations or bradycardia is generally short-lasting deceleration, while these chemoreceptor decelerations take longer to recover as they need fresh oxygenated blood so that it can wash out all the piled up carbon dioxide or lactate or hydrogen bonds in acidic medium. There are few fetal adaptive responses during labor, which we all should know. As we know, labor is a stressful condition for the baby. All uterine contraction causes around 60% reduction in uteroplacental perfusion, which can cause transient placental and fetal hypoxia. But a healthy fetal term baby with normally developed placenta would be able to combat these transient hypoxia by few adaptive responses, by even with decreased partial pressure of oxygen levels. It will trigger its chemoreceptors, which will further do the peripheral vasoconstriction, thereby so that the blood could centralize to the vital organs like brain, heart, and adrenals, so that the brain blood is maintained. It also decreases the fetal heart rate so that the heart oxygen consumption of its own is reduced and the end diastolic volume and cardiac output is maintained or increased, which maintains the cerebral perfusion. All these adaptive changes will make sure that it doesn't cause any adverse or permanent outcomes or problems in the baby. But what happens when this hypoxia continues and there is no static oxygen present for aerobic glucose metabolism? Then obviously fetus has to turn or restrict itself to anabolic metabolism, which we all know is there is a byproduct is lactic acid or pyruvic acid. Although it is less efficient, it produces less energy comparatively to aerobic phase, but it produces lactic acid as well. So the pH starts reducing. That then comes the our buffer systems. These buffer systems like bicarbonate mainly comes in action, but if hypoxia continues and this buffer system gets exhausted, then lactic acid starts to accumulate in the tissue and the blood, resulting in metabolic acidosis. And if it further goes on, then it can actually lead to fetal decompensation and permanent damage. What about the patient? What about the fetus? If it is already compromised in the form of fetal growth restriction, PIH, or type 1 diabetes, or there is already a placental damage in abruption or chorioamnitis, or if there is uterine hyperstimulation, the myocardial glycogen stores vanishes or exhaust very fast in these babies, so that the myocardium or the heart stops responsive, getting less responsive, reducing the systemic blood pressure, thereby reducing the cerebral as well as heart perfusion, causing the permanent myocardial hypoxic damage or the neural damage, leading to hypoxic ischemic encephalopathy. So how these theory of physiology could be represented on CTG? First is absence of acceleration. Although presence of acceleration is always reassuring, as I told you, because acceleration means that baby has efficient and good amount of energy and oxygen level maintained. But if there is absence of acceleration, that means it could be indicated that it is preserving its energy to conserve energy for the vital organs. But it is not always an unfavorable sign. We should mind this. This is a very asterisk mark thing, that there could be absence of acceleration in a normal labor. In otherwise normal CTG trace, absence of acceleration would not indicate an acidosis. It is the presence of other signs also we have to see. Then there could be loss of variability. Metabolic acidosis could cause depression of the fetal brainstem or the heart, which itself can cause loss of variability. Then there could be decelerations, which could be early, like when there is a with contractions, when there is pressure on fetal head because of cervix or the pelvis, the vagal nerve gets stimulated, which causes fetal heart rate deceleration, which is very common in active labor. But these early decelerations are not usually associated with fetal hypoxia, acidemia, or low UPCAR scores. Variable deceleration, as we all know, is because of cord compression. As the cord starts to compress, first, initially, the thin walled umbilical vein gets compressed, which further decreases the fetal cardiac outputs. That leads to a compensatory increase in fetal heart rate. This intensifies, further, this compression intensifies, the umbilical arteries also get compressed. Once they get compressed, the systolic or systolic blood pressure rises. Yes.
Sorry to interrupt, but there's just 1 minute left. So please, can you just wind up?
Sure, sir, ma'am. So systolic blood pressure rises, the vagal mediated decelerations are there. As these contraction abates, all this reverses. So we can see there is acceleration, which are called as shoulders, which is a compensatory situation for the baby. But there are a few concerning characteristics in variable deceleration, like when if it goes below 60 beat, lasts for more than 60 seconds, there are reduced variability during the deceleration, or it doesn't come to its baseline, there is no shouldering, absence of shouldering, or it become V-shape. Instead of V-shape, it's become U-shape or W-shape. Late decelerations reflect usually the reduced baseline uterine perfusion or placental function. Then with these adaptive responses, the fetus can become completely decompensated because of loss CNS hypoxia, which leads to loss of variability, or there are concerning features in variable deceleration. There are frequent deeper late deceleration, or because of catecholamine release, it could lead to fetal tachycardia. This step ladder type of pattern out to death leads to terminal fetal cardia or myocardial depression in the baby, which could lead to permanent damage in the baby. So we should ask ourselves, does this fetus have good reserve? Is the fetus compensating to these intrauterine stress? Is there any evidence of decompensating? We should remember every baby is different, each cord is different, each contraction is different. So to summarize, CTG patterns are just interwoven factors which should be, if properly understood, can help in improve the interpretation during the labor and also improves the outcome. The whole day is there to learn the terminology, interpretation, and courses of action. I hope I'm able to give you a good briefings about the physiology. Thank you.
Thank you, madam. That was a very nice presentation. Now, I think for the discussion part, any question and answer, we can have them at the end of the session. The next topic is by Dr. Nadia Khurshid. She is presently working as an assistant professor at Government Medical College, Baramulla. Her topic is the obstetrician and CTG. Dr. Nadia?
Yes, ma'am. I'll start sharing my screen.
Yes.
I'm not able to start my screen.
You'll be, I think now you'll be able to share your screen.
Yes, ma'am. Good afternoon, everyone. Today in my 10 minutes talk, I'll try to discuss the basics of CTG, the part of CTG machine. Cardiotocography, as we all know, it is a graphic record of the fetal heart rate and uterine contractions during labor. The machine used to perform the monitoring is called the cardiotocograph, more commonly which is known as the electronic fetal monitoring. These are the parts of the CTG machine, which comprises of a Doppler transducer, the toco, the graph, and the fetal monitor. We'll start with the cardio part of the cardiotocograph, which records the features of the fetal heart rate. It is done by two methods, the non-invasive and the invasive method. This is a trans-abdominal or the non-invasive method, wherein the Doppler transducer is placed over the anterior shoulder of the fetus. It is repositioned until we get a good signal. An ultrasonic gel is placed between the Doppler transducer and the abdominal wall. The ultrasonic gel has a similar density to that of the abdominal wall, so that the sound waves that travel through it do not face any interference. Fetal heart rate is recorded on a CTG paper and displayed on the CTG monitor. Transducer is a piezoelectric crystal which both generates and receives the ultrasonic waves. When sound waves generated by the transducer, they hit a moving object, for example, the fetal cardiac chambers, the frequency of the reflected sound waves will be altered. That results in the Doppler shift. It is this Doppler shift that is determined by the Doppler ultrasound within the fetal circulation. This results in approximation of true heart rate intervals. This is considered to be sufficiently accurate for analysis. External fetal heart rate monitoring is more prone to signal loss, monitoring of maternal heart rate, signal artifacts such as double counting and half counting, and it may not record fetal cardiac arrhythmias accurately. Talking of the fetal scalp electrode, it is an invasive method wherein the electrode it is attached to the baby's head, and it can also be applied to the breech. It is very important that before applying the electrode, there should be clear identification of the presenting part, so that the delicate fetus structures such as sutures and the fontanelles, they should be avoided. For this method to be suitable, the membranes must either be ruptured or they have to be artificially ruptured, and there should be sufficient dilatation of the cervix. Fetal heart rate by internal monitoring is measured by the time between R waves on the fetal ECGs. These measure the ventricular depolarization cycles. Internal monitoring cannot be done in patients who have an active genital herpes infection, hepatitis B, C, D, and HIV, or who are having suspected fetal blood disorders. There is uncertainty about the presenting part, or when artificial rupture of membranes is inappropriate. This is a slide which is showing the internal method of monitoring, wherein a scalp electrode, we can see that this is a scalp electrode and this is a internal pressure monitor. After proper consent and positioning and meeting all the prerequisites, a long plastic electrode guide is inserted through the vagina. There is a small spiral electrode that is attached at the end. It is placed against the fetal part, fetal head, and then gently rotated into the fetal skin. The guide is removed and the electrode is left in place. The electrode wires are then attached to the cables of the monitor, and fetal monitoring is done with this. The second part is the toco part that measures the uterine activity. Similarly, it is done by two methods. One is the transabdominal and another is with the help of the internal pressure transducer. In the abdominal method, the toco is placed on the anterior abdominal wall over the fundus and it is held in place by a stretchy elastic band. It is important to note that it monitors the frequency and duration. It does not reflect the strength of uterine contraction. Amplitude of the tocograph is measured as a pressure wave which occurs due to the change in the shape and the tone of the anterior abdominal wall. Other factors like vomiting, coughing, pushing, or Valsalva, they can change the shape and tone of the abdominal wall. So the recording on tocograph does not always represent the uterine activity. Incorrect placement, reduced tension applied to the supporting elastic band, or obesity, these can result in failed or inadequate registration of contractions. When information on strength or precise timing of contractions is needed, an internal tocometer is more appropriate. Coming to the internal pressure transducers. Internal pressure monitoring is done with the help of an intrauterine pressure catheter that has a pressure transducer attached at the tip. In theory, they do offer us a more accurate measurement of the strength and the timing of contraction, including the resting tone, but they are rarely used outside the research context. Intrauterine pressure, intrauterine activity is quantified by measuring the Montevideo units, which is calculated by adding together the amplitude of each contraction in 10 minutes. Amplitude is calculated by subtracting the baseline pressure from the peak intensity of each contraction. The third part of the CTG is the graph. In the graph, the upper part displays the fetal heart rates and the lower part, the uterine activity. All traces, they should be identified with unique patient identifiers, correct time and date. It is important that the paper should be loaded in correct orientation. One should be aware of the speed of the paper, which can be 1 centimeter, 2 or 3. In most countries, 1 centimeter per minute is selected, while in North America and Japan, it's usually 3 centimeter. Vertical scale used maybe 20 or 30 beats per minute. Some experts feel that a speed of 1 centimeter per minute provides sufficient details for clinical analysis, and it has the advantage of reduced tracing length. Others feel that small details in the CTG are better evaluated using higher paper speeds. It is important to note whatever the paper scales are used in each centers. The healthcare professionals, they should be familiar with this because the tracing interpretation, it depends on the pattern recognition. And these patterns may differ. As we see in the slide, the upper one is showing, this is a trace with a speed of 1 centimeter. The second is 2 and 3. A person who is accustomed to 1 centimeter per minute, he will find that the tracings will show a reduced variability in a trace of 3 centimeter per minute. The
Dr.
CTG,
Nadia?
yes, ma'am.
Just 1 minute left, so please wind up.
The paper can be inserted in the handheld notes and can travel with the patient. It is important to note that it is a thermosensitive paper and it has to be stored in dark colored envelopes. For risk management, it has to be photocopied and placed in the maternal notes. Electronic display, it allows CTG to be displayed both in the room and the central monitor so that the obstetrician can monitor multiple CTGs, more than one woman at a time. Monitoring should be done in lateral recumbent, half sitting in upright position to avoid aortocaval compression. The disadvantage of being restricted to the bed can be overcome by use of portable sensors that transmit signals wirelessly to the remote fetal monitor. Monitoring of twins should be done with the help of a dual channel monitors. Then computerized CTG, since we know the major drawback of cardiotocography is the intra and inter-observer reliability in interpreting the traces. This can be overcome by use of computer algorithms, but this has not been shown to improve any perinatal outcome. Now, what are the pitfalls in CTG? One is doubling of the fetal heart rate. If the baseline fetal heart rate is less than 100, sometimes the CTG machine may double the heart rate. So a fetal heart rate of 60 will be picked up as 120. A change in the baseline heart rate, absence of accelerations, and reduction in the baseline variability may give a clue to doubling.
Dr. Nadia, sorry to interrupt, but the time is up.
I'm just about to finish. Then halving of fetal heart rate. If the baseline fetal heart rate is more than 200, it can be halved and we can see a fetal heart rate of 100. We can sometimes see a erroneous monitoring of maternal heart rate as fetal heart rate, a loss of contact, incorrect placement of a thermosensitive paper. Thank you, ma'am.
Thank you, Dr. Nadia. I think that was a very nice presentation on the basics of CTG. And now I hand over the mic to Dr. Arifa Anwar for the second session, that is interpretation.
Dr. Sumedha, can we have 1 or 2 questions? Dr. Sumedha?
There are no
Dr.
questions in
Sumedha,
the
can we
chat
have
box.
1 or 2 questions?
And there are no questions in the chat boxes yet.
Okay.
So whenever we get questions, I think we can have the discussion there.
Right.
Now for the second session, I hand over the mic to Dr. Arifa Anwar. She is an associate professor at Hamdard Institute of Medical Sciences and Research. Dr. Arifa.
Good afternoon, everyone. I welcome everyone
Dr.
again. I welcome everyone here again to our ongoing second session on CTG. I am honored to introduce my colleague and very good friend, Dr. Aisha Ahmad. She is joining us from ERA Medical College, Lucknow. She is an MRCOG and a fellow in advanced laparoscopic surgery and obstetric ultrasound. She is going to speak on another colleague of ours, that is Dr. C. Bravado's approach to CTG. Dr. Aisha.
Thank you, ma'am. Shares. Ma'am, is my screen visible?
Yeah. Yeah, Aisha, your screen is, Dr. Aisha, it is visible. You can go ahead.
So, good afternoon, ladies and gentlemen. At the outset, I would like to thank the organizers for giving me a chance to share my views on this platform. We've seen 3 interesting talks already about CTG just now, and continuing with the discussion, I'm going to talk on the DRC Bravado approach to interpretation of a CTG trace. At the end of the day,
Aisha, there is some disturbance in your side. Can you see to it? There is some disturbance.
sorry,
Some disturbance is there.
disturbance
Some
fan.
background sound is there.
Okay, fan. At the end of the day, our aim remains to find out how well oxygenated our baby is. So now, in an adult, we can easily determine this by, just taking a blood sample and finding out the pH, the partial pressure of oxygen. Obviously, this is not possible in a fetus unless we resort to invasive procedures. So what we do is that we do the next best thing. We try to assess the changes in fetal heart rate, knowing that they are dependent on the pH levels. Now, we've already had a discussion on this, so I would not like to go into detail. I would just like to summarize that we know that chemoreceptors, they are sensitive to pH and hypoxia changes. They send signals to the brain, and this results in alteration of the fetal heart rate. So indirectly, when we are measuring the changes in the fetal heart rate, we are actually evaluating the pH of the baby, and that's what we want to determine whether there is hypoxemia or not. Now, just a word on the response to hypoxic stress, difference between adult and a fetus. So what happens when we get hypoxic? We increase the rate and depth of respiration. Obviously, a fetus can't do that. So it does the next best thing. It decreases its heart rate to reduce the myocardial workload. Now, in case the hypoxic stress continues, the fetus tries to conserve energy by stopping all non-essential activity, and the mother will complain of absent fetal movements, and we will find loss of accelerations in CTG. If the hypoxia continues, so there's release of catecholamines and we have fetal tachycardia. So what actually happens initially is that we have small variable decelerations, which might still be in the normal range of 110 to 160, followed by loss of accelerations, followed by tachycardia. And then baseline variability is lost, which is finally, followed by late decelerations and progressive decrease in fetal heart rate. The stepwise pattern that we've already discussed. Now, having understood these concepts, we come to this mnemonic, which has been introduced so that we don't miss out on any aspect while interpreting a CTG. DR, or determine risk, or detect risk. So, this is just over here so that, it should serve as a guide that we need to evaluate the entire clinical situation, just as we heard Dr. Tripathi reiterating it again and again. Because we should not take decisions based on the isolated features of a CTG strip. So the risks could be maternal, fetal, intrapartum, oxytocin infusion. For instance, the RCOG guideline says that, you put a woman to continuous CTG in case oxytocin infusion is started. Contraction. So when we talk of contractions, we are talking of frequency, how strong the contractions are, what is the duration, and what is the resting tone. And obviously the resting tone, it will depend on, it depends on many factors. The intrinsic tone of the uterine muscle, liquor, any evidence of abruption. And how do we assess the uterine contractions? So for long we've been doing this subjective assessment of mild, moderate and good, and we find it pretty good for our clinical use. Unfortunately, most of the studies have found that the accuracy of this is, by the usual obstetricians, when they do this assessment, the accuracy is 49%, and which might be as high as 58% when it is done by the MFM specialists, which is also not that great. Then we have studies, extrapolating what exactly do these contractions mean when we talk in terms of pressure. So a good contraction usually means an intrauterine pressure of more than 50 millimeters of mercury. Montevideo unit, we've all heard of it in the previous lecture. So when we talk of Montevideo unit, we talk of Caldairo Barcia, the genius obstetrician who was working in Montevideo, and the one to whom we attribute introduction of the type 2 dip and the introduction of trocholysis for fetal distress. So this is another method wherein we can, assess uterine contractions. And then finally, we come to Professor Philip Steer, Professor Emeritus, Imperial College London, and he is credited as the one who advocates the use of kilopascal because it's an SI unit, and if you have a look at your CTG strip, so you will find that the uterine pressure is measured in kilopascal to standardize things. Whichever way you use, whatever works for you, fine is fine. And just for your information, 1 millimeter of mercury is equal to 0.13 kilopascal, which essentially means that we need to have around 6 kilopascal for good uterine contractions. Baseline variability. So the mean fetal heart rate when it is stable, excluding accelerations and decelerations. And we need to have a segment of at least 2 minutes so that we can assess the baseline fetal heart rate. Now I've put together 2 strips just drive home the fact that it is always possible to calculate the baseline fetal heart rate, because nowhere am I finding a 2 minutes on to variability. So we've heard what variability is, that we look at the CTG strip and we find that there's a wiggliness of the baseline, which is basically, when it is present, so we are happy that the fetal autonomic nervous system is working fine. How to calculate variability? So variability is basically the difference between highest peak and lowest trough of fluctuation in a 1 minute segment of trace. Now I've put together 4 CTG films over here. So you can see that there's normal baseline variability over here. It is reduced in this film. It's still further reduced in this film. And what you see over here is that there is an increased variability, which is also called as the saltatory pattern and is pathognomonic of acute hypoxia or mechanical compression of cord. Next, we come to accelerations. So we know that accelerations are sudden rise of fetal heart rate from baseline by more than 15 beats or more than 15 seconds. Present, we are happy. Absent accelerations does not necessarily mean that there's some problem with the baby. The baby might well be just sleeping. Important for you to just realize is that in a fetus who's less than 32 weeks, for accelerations, we say it's 10 rise in baseline by 10 beats per minute for 10 seconds or more. Coming on to decelerations. So fall in baseline by more than 15 beats for more than 15 seconds. Now, when we talk of decelerations, so we talk in terms of type of decelerations, what is the duration, what is the depth of fall from baseline, how frequently the decelerations are occurring, and importantly, a concept which has been here for a long time, but recently introduced into the NICE guideline, variability within a deceleration. So these are early decelerations. When you see over here, these are just mirror images. The decels are mirror images of the uterine contractions. The contraction gets over and the deceleration is also fine. And these decelerations, they are not due to hypoxia, and mostly they're due to vagal stimulation due to head compression in second stage of labor. Now I've put together 3 strips from actual patients when we were doing a maternal audit. So these patients had second stage cesareans, and when we take a closer look, all of these are early decelerations. So it's very important to audit yourself and to re-audit yourself as Dr. Tripathi was introducing in the morning. Next, we come to variable decelerations. So decelerations which vary in shape, size and timing in relation to contractions. These are the most commonly observed decelerations. And when we talk of variable decels, I would like to introduce the concept of shouldering. So shouldering is the presence of acceleration before and after a deceleration. When you see these two images, shouldering is present over here also and over here also. But over here we call this as overshoot, and this overshoot is not it's a concerning feature. It's not something like a shouldering. Shouldering is just a very minor rise in heart rate. So this concept of shouldering, we've already had an introduction to it in the morning when we talked of cord compression, that initially we have compression of the umbilical vein, which is, causes this baroreceptor mediated acceleration initially, followed by decel, again followed by an acceleration when the process gets reversed. Now coming on to variability within a deceleration. So when you see this segment, you find that even in this decel, we can find a lot of variability, which is not present in this deceleration, and this is a concerning feature. Now this patient had two features: absent variability in this segment of the deceleration and a biphasic pattern or a W pattern, and both of these are concerning features. As NICE guideline lays out 5 features already discussed in the morning, so I would not like to go over these again, but these are concerning features of variable decelerations. Next, we come to late decelerations. So these are suggestive of myocardial depression, and these are chemoreceptor mediated. So when you see over here, even when the contraction gets over, the deceleration still has not reverted back to the normal baseline, and we find that there is a lag time. The more the lag time, the more hypoxemic the baby is. Another picture. So this is also a late deceleration, but you see that this is sustained deceleration. So although this is a late deceleration, but then it attains slightly greater significance because of the duration. And when you see that there is a technic uterine contractions over here, this was a patient of abruption. Another similar CTG. So this kind of deceleration, when you encounter, this is suggestive of acute hypoxia. And what is important about it is that 95% of them will recover by 9 minutes. And hence we have the recommendation by NICE that if the fetal heart recovers at any time up to 9 minutes, please reassess the decision to expedite birth of the baby. And in some books, we can also find this written as the 3-minute rule. So it's also the same thing, essentially. And finally, we come to overall impression. So this is going to be taken in the next lecture. But this is NICE guideline, and you can follow any guideline, the FIGO, NICE, ACOG, we have different guidelines. So finally, and I have quoted the NICE guideline. So finally, on the basis of all these features, we decide and categorize the CTG as normal, suspicious, pathological, or a CTG needing urgent intervention. Thank you.
Thank you, Dr. Aisha, for covering your topic on time and covering all the aspects, especially the Montevideo units and the Pascals, which is the basic thing or in CTG. And I would also request all the delegates to kindly put your queries or any questions in the chat box so that we can take it at the end of the session. Dr. Aisha, you can stop sharing. Now I welcome our second speaker, Dr. Shalini Malhotra, who's a consultant obstetrics and gynae and a robotic gynec surgeon at Al Qasimi Women and Children Hospital, UAE. She's joining us from UAE, and she's going to speak on how to classify CTG. I think after this, we will be able to optimize the interpretation of CTG. Dr. Shalini. Yeah. Dr. Shalini, please unmute yourself.
Right. Thank you so much, Dr. Arifa, for the kind invitation, for the kind introduction, and of course to AOGD and the organizers for this invitation to be a part of this event. I truly am honored to be in this on this platform, and it's amazing to be connected from this distance. So beginning with the topic and not wasting more time, classification of CTG. As has been very well elaborated by my previous speakers, CTG is nothing but an analysis of 4 features, and yet it is the one that makes us all decide what to do, how to do, and at times it surprises us with the outcome. So even though it looks very simple, it is something which is very complex, primarily because of the wide diversity in how to interpret it. CTG interpretation requires a very high level of skill and is subject to variation between clinicians, which can lead to inappropriate care and impact perinatal outcome adversely. This is what was reported in the Saving Babies Lives Care Bundle 2017 UK, which is one of the very standardized audits that are done. Healthy women in uncomplicated pregnancies are monitored by intermittent auscultation in labor. Having said that, in UAE, there is no unit that actually monitors women on intermittent auscultation. CTG is perhaps the only way that every lady, low risk or high risk, is monitored in UAE. And this is primarily because of the very, very high litigation rate in this part of the world. There are no babies that can be compromised. And therefore, on admission in labor, there should be a detailed admission of risk factors to decide the mode of monitoring. Having said that, UAE does definitely CTGs for everyone on admission and in labor. To begin by how we categorize, and then when I say that the entire UAE is based on CTG interpretation so much, we need to, this is just to emphasize that the classification we use to communicate about a trace to each other, especially working in a ministry hospital where we work in shifts, we have a team of specialists and GPs who are working, the terminology that we use and the standardization of that terminology is very, very important, which is where the importance of this lecture, that if we classify the CTG in a common way, we tend to make less mishaps. So the NICE guideline UK helps us classify the trace as normal, suspicious, and pathological. Normal trace is where all the features are in the reassuring category. Suspicious, where only one feature gets into the non-reassuring category. And pathological is when there's one feature abnormal and 2 non-reassuring. Of course, though my previous speaker mentioned a bit about this, but I would just convey it again. The features that we're speaking about are the baseline heart rate, the baseline variability, the decelerations, because accelerations are supposed to be present usually on an antenatal trace, and we do excuse them on an intrapartum trace. So accelerations are not usually a feature of an intrapartum trace. Therefore, the baseline rate is reassuring if it's 110 to 160, the variability is 5 to 25, and the decelerations are either none or variable. The non-reassuring categories for each, and the abnormal categories. So just to re-emphasize, a trace is normal if everything is reassuring. A trace is non-reassuring if the trace is suspicious if there is one of these features which is non-reassuring and the rest are reassuring. A trace is pathological if there's one feature that's abnormal, but the others are fine, or there are 2 non-reassuring features. The NICHD is the classification they use in US, which is more or less a similar classification. It says category 1, 2, and 3. Category 1 is absolutely normal. Category 3 is abnormal. And category 2 is anything that you cannot conclude on or indeterminate. Perhaps at times you find this simpler because it's really the suspicious ones that you're more worried about always. So category 1 is you follow her routinely. It's normally predictive of a normal acid-base status at the time of observation. Again, the important line here is at the time of observation. So a CTG never has a predictive value for beyond the testing time. Category 2 is not predictive of an abnormal fetal pH status, but since you're unable to classify it as 1 or 3, you need to promptly evaluate and have efforts to either improve the trace or take a decision. And category 3 is abnormal, definitely predictive of an abnormal fetal acid-base status. You need to promptly evaluate, intervene, and perhaps consider immediate delivery. So we usually use the fetal monitoring stoplight in our hospital, which tends to tell our physicians very clearly what is green and you can sit on the chair and relax, and what is red, you need to get up, pick up the phone, alert everyone, and get moving. And what helps them classify the trace or perhaps the care of the patient into these red, green, yellows is the Dr. C. Bravado mnemonic. Very commonly used. Of course, we owe gratitude to Dr. Kim for initiating it. We also train our physicians using the Advanced Life Support in Obs and Gynae course, and that uses Dr. C. Bravado essentially. So the green is the category 1, the red is the category 3, and the yellow is the category 5. So a category 1 trace is where you must have all these characteristics. The baseline 110 to 160, moderate variability, which is 5 to 25. Late or variable decelerations are usually absent, and early decelerations can be present or absent. Accelerations are usually present or absent. A category 2 is an indeterminate fetal heart rate tracing. They can present at some point during labor. More than 80% of the labors do get them sometimes. You could have a period of tachycardia, a period of absent, reduced baseline variability, sometimes recurrent variable decelerations with minimal to moderate variability, recurrent late decelerations, but they have moderate variability, variable decelerations with slow return, overshoots, prolonged decelerations, no accelerations after fetal stimulations. So we know all the labors have these at some point of time. But the category 3 ones are the abnormal ones, sinusoidal pattern or absent fetal heart rate variability with any of these following: recurrent late decelerations, recurrent variable decelerations, and bradycardia. So a sinusoidal pattern is a smooth sine wave-like undulating pattern in fetal heart rate baseline, normally at a cycle frequency of 3 to 5 per minute. If it persists more than 20 minutes, you need to consider ruling out narcotic-induced. Usually, the etiology is fetal anemia, fetal hemorrhage, RBC hemolysis, sensitization, or an evolving asphyxia. It could also represent a terminal pattern, so you really need to rapidly evaluate and respond to this trace. So that's all about the classification, and just a bit about how you manage it after the classification. Category 1, there is really no risk, so you just continue monitoring the lady in labor. Category 2 is an indeterminate risk. So if there was a lady in category 1 trace and there's no other risk factors, we'd normally let a midwife deliver her in my hospital. So if there's a category 2 trace and there's an indeterminate risk, of course, if there are any other risk factors in the case, perhaps the GP doctor would take up the delivery of this case. Or if there are no other risk factors, this would be reviewed by a GP again in some time till she can put the trace back as category 1, then hand her over to a midwife. And category 3 is, of course, high risk. Perhaps it would need a specialist intervention immediately on the floor. And the management plan, as Dr. Reva pointed out, and all the subsequent speakers very, very categorically pointed out, is always based on the clinical context. We do not deliver patients on a CTG. We do not manage them on a CTG. We must include a plan for further surveillance, even if we put an indeterminate trace as category 1 in some time. Very important slide, the stillbirth rates. A reactive NST, always a category 1, the stillbirth rates were 1.9 per 1,000 births. But a non-reactive NST, something like a category 3, they're 26 per 1,000. So it does help us to some point in trying to categorize or trying to improve the outcomes at the end of our deliveries. However, even after a reactive trace, there can be 2 babies dying in every 1,000 births. So it's just to make you understand that a reactive or a normal trace can also have poor outcomes sometimes. A false positive rate of an isolated non-reactive NST could be as high as 50 to 60%. And this being a cause of worry in the Ministry of Health, where we promote vaginal deliveries and avoid cesarean sections to a large extent, there's actually been an audit that we have started doing correlating the cesarean category 1 and 2 cesarean sections for fetal heart rate abnormality with the outcome. From 24 to 28 weeks of gestation, there are up to 50% of the NSTs which may not be normal. And from 28 to 32, this number reduces to 50%. And I don't think any one of you is guessing why. It's just because we need to understand, like Dr. Deva very nicely said, we need to understand the gestation of the fetus before we're able to read the trace, because at every gestation, there are different interpretations we can draw. When do we time CTG or initiate it? Well, in the UAE, we start at 26 to 28 weeks, and I'm sure it's the same everywhere else. We have had episodes where it was done at 24 weeks, and then we landed up operating with no major benefit. It's a very well, there's a very well quote I read that if you do think you want to initiate a CTG before 26 weeks, please make sure you also know how you're going to be monitoring and what you're going to be doing for that trace if it is abnormal. Because there are many features of an extremely premature trace which really are not abnormal, but you'll have to report them as abnormal if you want to pick them up. So prior to 32 weeks, we all know that accelerations can be less than about 10 beats per minute for 10 seconds. So that's one difference. And the baseline heart rate reduces as the gestation matures due to the maturation of the parasympathetic system. Thus, seeing heart rates above 160 per minute could be a normal variant in a preterm CTG, but would make our interpretation suspicious. And this reconfirms that we do not manage a CTG, but the patient, because sometimes you just have to ignore it even if you report it as a suspicious trace, just because of one feature. Nothing more helpful than the Dr. C. Bravado mnemonic. But when reviewing the trace, please assess and document contractions and other 4 features of the fetal heart rate trace. The NICE guidelines in UK always keep reminding us, do not make a decision about a woman's care in labor on the basis of CTG findings alone. Do take into account the woman's preference, the risk factors, the well-being of the woman and the unborn fetus and the progress of labor. And please ensure that the focus of care remains on the woman rather than the CTG trace. And a very, very important quote. So what are the other important considerations while planning care? So even though the classification could be normal, suspicious, pathological, you need to make sure that you understand the whole context. You need to have a complete assessment of the maternal vital signs, perform a vaginal examination to understand the progress of labor, rule out a prolapsed umbilical cord, change the method of fetal heart rate monitoring if the strip is inadequate quality. If recent epidural and hypotension with late decelerations, you must consider further interventions. Other intrauterine resuscitative measures, which all of you know, which help us move a suspicious trace into perhaps a normal. Whereas the possible interventions could be changing the maternal position, administering maternal oxygen, IV fluid, reducing the contraction frequency, discontinuing oxytocin, administering tocolytic drug, initiating amnio infusion, modifying pushing efforts. That's the end. So even though I've ended my talk, the most important message is classification of CTG based on all the 4 important features are very important. On all the 4 features is very important. Even in this part of the world, we still have litigations and liability committees getting major complaints of famous obstetricians only for poor outcomes at the end of CTG. We in UAE do a yearly mandatory training course for all in the ministry for CTG interpretation. So that's the importance we give to CTG here. Thank you.
Thank you so much, Dr. Shalini, for enlightening us with the interpretation of CTG, especially the medico-legal part of it. And now I request all the delegates to kindly take a screenshot of the I request the delegates to kindly take the screenshot for the Google form. It has some 15 questions, and you can answer those questions and post us back. Also, you can also put your questions in the chat box so that we can take it at the end of the session. I welcome our last speaker for the session, Dr. Chantal, with her beautiful smile as ever, and who's a senior consultant, fetal medicine and Rainbow Hospital. I would like to invite her for the talk on CTG in special situations. Dr. Chanchal.
Thank you, Dr. Arifa. I would like to thank the organizers, especially Dr. Reva and Dr. Anna Nigam, to give me this opportunity. without wasting much time, I'll go on to share my screen. Oh, just a minute. So the topic that has been allotted to me is CTG in special situations. The previous speakers have made my job very easy by enumerating the classification systems, how to classify, how to read the CTG. So in the last RCOG conference in Calcutta, one of the topics allotted to the speaker was, is CTG voodoo or science? So I found it very appropriate, because knowledge and without correct application would be voodoo, whereas if you apply knowledge to the correct application, only then it becomes a science. And that's true for CTG. Now, as the previous speaker outlined the various guidelines, most of us are using NICE guidelines, which are quite similar to the FIGO consensus. And as she said, that use any guideline, but stick to one guideline, because if you are trying to convey that it is a suspicious CTG and your colleague is thinking of it as a category 1 or a category 2, it will lead to miscommunication. So a quick recap of a CTG trace: draw a straight line to look at the baseline, look at the date, time, the patient name, all this should be put correctly on the trace. Look at the duration and the number of contractions. Don't forget the contractions, not just the 4 features. You draw a straight line through the top of the trace to the bottom of the trace in any 1 minute segment, and that would be your variability. And then there are accelerations and decelerations. Now, decelerations are very common. An intrapartum trace would have decelerations. The key is to differentiate the significant ones from the non-significant ones. And the most significant parameter is the duration in which the CTG is recovering. So any trace which the deceleration which is recovering within a minute is very well tolerated. And the NICE, as per the new modification, says you can look at them for almost 90 minutes before you need to do anything. Whereas these kind of deceleration should recover within half an hour. And that is the most important feature of knowing what is reassuring, what is non-reassuring, or frankly abnormal. Now, going on to some cases, I'll just show a couple of cases. Now, case 1, 26-year-old, low risk priming gravida, admitted at 39 weeks in labor. On admission, she was already 2 centimeter dilated, fully effaced. Station was -2. The membranes were ruptured. There was clear leaking. And the first special situation that I'm dealing with is cento augmentation, because all of us are going to encounter it for majority of our patients. So she was augmented with oxytocin. Then she requested epidural for pain relief. And while we were waiting for pain relief, this was the trace. So enough to give all of us quite a scare. So now, do not get inundated by the most prominent feature on the CTG. As previously elucidated, look for all 4 features. So the baseline is 145. The variability is maintained. There is a prolonged deceleration of almost 5 minutes. This would fall into the category of a prolonged deceleration. And the heart rate recovered, but then it went down again. And look at the contractions here. So now, when you see this kind of a trace in your labor ward, this I think is a very appropriate reaction. However, do not panic. And so the NICE very beautifully in its latest update has divided abnormal CTGs into those that require further investigation, vis-a-vis those require an urgent intervention. So a prolonged bradycardia lasting for more than 3 minutes is recognized as an abnormal CTG that needs urgent intervention. And therein comes the 3, 6, 9, 12-minute rule, wherein if there is bradycardia beyond 3 minutes, you start reassessing the patient, put her in left lateral, give her fluids. If it has not recovered by 9 minutes, you start speaking to the patient about delivery. And by 12 minutes, if it has not recovered, you would proceed with an emergency delivery, the mode of delivery being dependent on the vaginal examination findings. However, they also state that if it recovers within 9 minutes, you reconsider the decision to expedite delivery in discussion with the mother. So here, the reason I put it as a CTG, which in special situation is, can you see any apparent cause for this prolonged deceleration? So if you look at the bottom of the trace, you can see how closely placed the uterine contractions are and the strength of the contractions. So this is actually a case of hyperstimulation. So the centosinon was stopped, the CTG recovered. A repeat vaginal examination after an hour showed that the patient was already fully dilated. It was an ROP. The cento was restarted, but that started again, the deceleration started again. So a vacuum was applied. A baby boy weighing 2.9 kg with an APGAR of 6.9 was born. You can see the trace on the right side. Once you stop the centosinon, it recovered. The reason why one would want to emphasize on augmentation in labor, oxytocin is like putting the baby underwater. The more you have to give the baby enough time to come out of water, take enough breaths so that the lactic acidosis, the metabolic acidosis does not get time to accumulate. The causes of fetal hypoxia with cento augmentation are the most common reason for inadequate care. As Dr. Tripathi highlighted in her talk, as part of the EMBRACE study, they found that most of the cases where there was fetal hypoxemia, the reason was because of an improper monitoring with cento augmentation. And commencement, so inadequate uterine contraction monitoring could be a cause. So one must really take care that the transducer is picking up uterine contractions. There could be poor technical quality of the heart race, cessation of monitoring the fetal heart rate. We often find when we are looking at the CTG traces that till the time the patient was 10 centimeter, I've got a beautiful trace. However, those last critical half an hour, 45 minutes, the trace is just gone, or it is just traces of the line on the graph. So it is very important that the trace must be recorded very clearly. Then the oxytocin, when there are major risk factors, should not be recommenced. For example, when there is thick MSL, or there is an evidence of chorioamnionitis, or when there is a suspicion of abnormal trace, and the failure to recognize hyperstimulation. These were the causes that were found responsible for suboptimal or substandard care in patients who did not have a good outcome. Coming to case 2, 19-year-old priming gravida, 39 weeks. She has been leaking for 18 hours and came to the emergency with irregular contractions. Her BP was 140 by 90. Urine albumin was 2+. On speculum examination, one could see definite leaking. On vaginal examination, she was 1 centimeter dilated. However, the cervix was still 1 centimeter long, thick, membranes were intact, and the station was -3. Decision was taken to induce labor with misoprostol sublingual in view of term from preeclampsia. And she was reviewed after 6 hours. The CTG was reassuring. However, the patient had spontaneous rupture of membranes, and the vaginal examination was repeated. She was still 1 centimeter dilated, but partially effaced, membranes ruptured, station -3, no cord. And you can see that with this vaginal, she was transferred to the labor ward and the vaginal examination was done. So you can see at the bottom of the trace that she's getting about 3 contractions in 10 minutes. And the baseline is 160, the variability is maintained, there are accelerations and there are no decelerations. This was at 11:47 in the night. Now, this was at 11:47, then at 12 midnight, suddenly you can see the change in the trace. What's happening here? So if you were to look at the trace, again, don't get carried away by the most, what is the most prominent feature. We still look at the baseline. The baseline is still 140. There are decelerations. The loss of beats is more than 60 beats per minute. And they're taking longer than a minute to recover. So this is definitely an abnormal feature. And here you have a bradycardia. So fetal heart is recovering. So what would one do? Any change in the trace, even if I've done a vaginal examination 5 minutes earlier, any change of a trace to an abnormal trace deserves a re-examination, both abdominal, general physical, as well as vaginal examination. So you can see that the CTG, despite left lateral and hydration, the CTG remained, you can see deep decelerations which are taking longer than a minute. So the examination was, the vaginal examination, the mother was not hypotensive. She had not just received an epidural. The vaginal examination had just been done 10 minutes earlier. However, because of the CTG, We repeated the vaginal examination and it was a cord prolapse. So the person who was doing the vaginal examination kept her finger inside. Digital elevation of the head was continued. A Foley's was inserted with Wilsonine. The foot end was elevated, and the patient was shifted to the OT on the bed, on the labor ward bed. And an emergency cesarean was done under general anesthesia. The decision to delivery time was 12 minutes. The baby was delivered as cephalic, had an APGAR of 4-7. 7 was kept under observation, and both the mother and baby were discharged well in post of day 4. So the main reason to put in this CTG was, even if you've examined the patient 10 minutes ago and there is a sudden change, please repeat the complete examination. Case 3 is a special situation which we all fear. A priming gravida, 32 weeks, came to us with leaking since last 72 hours. And if you look at the trace, the fetal heart rate is about 165, 170. And the variability, if you just draw a line through the top and the bottom, it's more than 5. However, if you take a closer look at the CTG, the most striking characteristic of this trace is that within the fluctuation, there is no beat to beat variability. This is a true sinusoidal pattern. And if you look at it in the context of the patient's history, she had been leaking for 72 hours. So a very high risk candidate for a chorioamnionitis. So there are no accelerations, no decelerations you can't really comment on. So this is, I've just enlarged this part of the trace, and you can see the contrast between all the CTGs we've just seen. Aisha was talking about the variability within the decelerations. And you realize that within that CTG, there's hardly any beat to beat variability. So this is a sinusoidal trace. And the patient had a very poor bishop. An emergency cesarean was done, 1.8 kg baby with an APGAR of 5.6. The cord pH was only 6.9. And the neonate had Klebsiella septicemia. Eventually, the baby did go home, but the CTG must be interpreted in the clinical context. Now, another CTG. So if you were to, this is an antepartum trace, you can see there are no contractions here. And this is a situation which we are increasingly encountering. So prematurity. We are, as the neonatal care facilities are getting better and the incidence of preeclampsia is just not going down, we need to monitor babies, premature babies, take decisions to deliver them. There are no guidelines or interpretation in premature fetuses. All the guidelines that have been outlined before are for fetuses 37 weeks plus. Depending on the gestational age at which an institution is comfortable as taking decisions in favor of the fetus, anywhere between 28 to 32 weeks, you can use the CTG. However, one must remember that these fetuses have a baseline tachycardia. The variability is less as compared to a term fetus. And the only feature probably that should prompt an action is persistent decelerations, which are taking, where the loss of beats is more than small dips you will find very frequently in premature fetuses. So persistent decelerations where the loss of beats is more than 60 beats per minute, those are the ones that should prompt any action. Fifth case, 32-year-old priming gravida, no significant medical surgical history. The antepartum period was uneventful. And she came to the emergency at 27 weeks. She had an anomaly scan which was normal with decreased fetal movements. There was no complaint of pain, vaginal bleeding or leaking. And the fetal heart rate was localized with a lot of difficulty on this trace. And you look at this trace, the mother's pulse was 82. So it was not being confused with the mother's pulse. It was 88 or 90. This fetal heart rate was 80. Now, what should be done next? She is not in labor. You can see there are no contractions and there is hardly any activity here. It is just a flat line of 80 beats per minute. So as in the emergency, she was put in left lateral IV fluids admission. But we decided, let's look at the baby on the ultrasound. We didn't want to be doing a section for an IUD. On the ultrasound, the fetal heart rate was only 80. She was seen last at 20 weeks, came for an antenatal visit at 28 weeks. The heart blocks are notorious to develop in late second trimester or early third trimester. So this was actually a congenital heart block. And this is usually what happens in these young girls where you discover the autoimmune disease once you see the heart block on the ultrasound. So She was the growth, amniotic fluid, the Dopplers, they were normal. There were good movements on the scan. And as she as expected, she was anti-Rho, anti-La positive. So she was monitored with 2 weekly ultrasounds, and on inquiring about history, she gave history of vague joint pains, nothing really that required intervention or investigation. This fetus we managed to pull till 37 weeks, wherein an elective cesarean was done. So I always like to talk about the fifth component of the CTG. That is the CTG at the start or at the admission, baseline CTG. So if we have time, we'll just cover this last case. Do we have the time? I'll just quickly finish this last case. So priming gravida, 34 weeks. Again, a preterm fetus, came with abdominal pain and vaginal bleeding. The vitals were stable, os was closed, placenta was not low-lying. Now, when you look at this trace, it doesn't look really bad. It doesn't look very intimidating. But however, once you start looking at it, you can see that she's contracting. So she is definitely in threatened preterm labor. She's contracting thrice in 10 minutes. The baseline is about 160. Variability is acceptable, about 5 beats per minute. There are no accelerations. However, you see at regular intervals, in fact, coinciding with the contractions, every time the patient gets a contraction, the heart rate drops. By definition, decelerations are a loss of heartbeat of more than 15 beats per minute. Here, the loss may not be so much, especially if you look at the initial 2 decelerations. However, that's the problem with these late decelerations, that the drop is not, so we have no problem in recognizing variable deceleration because the drop is.
Somebody else, can you explain the pathophysiology of W-shaped CTG?
I think somebody's got the mic on. So these are these late deceleration. And if you time them according to the contraction, you can see that the contraction has long subsided, but the deceleration has not gone. So these are late deceleration. Late deceleration, fetal tachycardia, this is a definitely abnormal trace and needs intervention. See, every time I'm drawing a line through the trace, you can see that these are late decelerations. And so the decision was taken for an emergency cesarean in view of suspected abruption. And the patient did have indeed abruption. A baby boy weighing 1.8 kilograms was born. The APGAR was 9.9, and there were retroplacental clots. One comment on the maternal trace. So this was now.
I think time is over. You can wind up, Dr. Chanchal.
I'll just come to my last slide. So CTG interpretation needs to be individualized, as has been highlighted with all previous speakers. And special situations deserve special recognition. The same trace will not have the same implication for a growth-restricted fetus as compared to an appropriately grown fetus. We must have a systematic approach, a proper terminology, correct classification, and I think the crux is to differentiate significant from non-significant CTG changes and having effective communication. So as all my previous speakers have said, treat the patient, not the CTG. Thank you very much.
Thank you, Dr. Chanchal, for explaining such clinical-based CTGs with the discussion. Now, I will just ask the few questions which are there in the chat box from the speakers. First question goes to Dr. Nadia. Dr. Nadia, are you there? Dr. Nadia? Dr. Nadia?
I can find out Nadia. So you can ask Aisha.
Dr. Aisha, can you please answer how long one has to keep the CTG to be kept it for medical legal purpose?
Especially if it's a medical legal case, CTG for as long as you know the survival. For instance, if it's a case of like severe birth asphyxia, if it's a case which will have medical legal implications. Otherwise, we keep the traces for 25 years.
Anybody from the house?
कब milestone delay हो गए मालूम नहीं? I'm just saying, एक एक साल आजकल केसेस करने लगे लोग कि माइलस्टोन्स डिले हो गए
Ma'am,
25 years routinely.
routinely, but in case, we expect that it can have medical legal implications, as in it's a birth asphyxia or anything, then we need to keep it, for as long as, the lifespan of the individual.
I think Dr. Reva wants to.
But do you think that that's a practical approach? Will you be able to keep so many CTGs for 25 years, even if you microfilm them? And then the other issue is, what is the longevity of your ECG trace? Because it's a thermal paper.
Ma'am, scan them.
So,
We can scan the CTGs.
yes. So then either one should make it a point that in those patients whom we think that there is a problem or there may be a chance of a medical legal, you scan them and store them in a microfilm way, so that you probably don't need to do that for all the traces, but certainly for the ones that have a problem, I think it would be a good idea.
They say you scan it and put in a cloud. कहीं भी जाए आपकी hard disk भी खराब हो तो you put in a cloud so that it will be there for life till he or she marries. Any other question?
Yeah, the second question is from Dr. Shalini. Dr. Shalini. Yeah, this is how often you people keep your take out the CTG strips in UAE and keep, how often during labor?
Well, for every okay, so in labor. So I would just continuing the previous question, we in UAE tend to save them for about 10 years because we have the electronic fetal monitoring and it gets integrated with our electronic records. We don't have files. So therefore, the traces are always kept in the electronic file of the patient for at least 10 years because usually if there's a problem, they would go to court before that. Well, in labor, if it's a low-risk labor, we tend to monitor every 4 hours because there is one assessment every 4 hours. But if it's the second stage and if there's any other indication, then it's a continuous monitoring in second stage. To answer that question.
Thank you so much. My next question goes to Dr. Shelley. Dr. Shelley, can you please explain the pathophysiology of W shape in CTG strip?
I think Dr. Shelley, Dr. Chanchal can explain. Shelley is not there.
So whenever there is a contraction, the cord gets compressed. And the vein, because it is thinner, it collapses first. And it triggers the beta receptor and the chemoreceptors, and the fetal heart rate dips. It increases before it falls. So when the contraction is coming, first the vein collapses, and then it becomes strong enough to collapse the artery. And that is what causes the dip. In between, when it relaxes, so the vein will uncollapse first, and there will be a trigger. It will go up. And the shouldering is explained by this. So in the W shape, what is happening is that the contraction, either because of hyperstimulation or anything, it is not giving the cord enough time to come back to its original state. And that is why they are more worrying that the baby is not getting enough time to recover. So the W-shaped that is why traditionally they considered more ominous than other D-cell patients.
Thank you so much, Dr. Chanchal, for explaining it so nicely to the audience and the delegates.
I think
now I request
taken all my cases.
Okay.
With the panel right now.
Now I thank all the speakers for the beautiful presentation, and I hand over the session to our next moderator, Dr. Nidhi. She's an assistant professor at Jamia Hamdard. Dr. Nidhi.
Thank you, Dr. Arifa. Now we will start our third session. I will like to invite our third speaker. The first speaker of this session, Dr. Smriti Agarwal. She is additional professor at KGMU Lucknow. She has been a core member to revise various guidelines in medical disorders, genital tuberculosis, and emergency obstetrical care curriculum. Dr. Smriti. She will be presenting on computerized CTG.
All right. Okay, can you stop screen sharing so I can start my...
Yes, over to Dr. Smriti.
All right, are my slides visible?
Yes, very much.
Okay, a very good afternoon, Dr. Aruna. Thank you so much, and thank you, Reva ma'am, for giving me this opportunity. I look forward to meeting you people more often. I would like to speak today on continuous CTG and STAN in labor. These are advanced technologies which are used for intrapartum fetal monitoring, and we will quickly overview what exactly they imply. So in these 15 minutes, I would be speaking about why we need tests for advanced fetal monitoring, what is continuous CTG, what are the advantages and limitations, what is STAN, how is it interpreted, and what are the uses of STAN, and ultimately, what do the guidelines say? Should we go for it or not? So as we have been hearing in the last 1 or 2 hours about CTG monitoring in labor, we know that CTG monitoring is good enough and we have all been using it for many years. Now, the problem is, why do we need advanced fetal monitoring? The reason is because there are certain unexpected complications which can occur anytime, and we all agree to it. Even in patients who have no prior risk are also land up in certain unexpected complications and then subsequent litigations. And advanced fetal monitoring as such is also appropriate in cases where we augment the labor, when we like to give epidural analgesia for labor pain relief, and maternal high-risk conditions like preeclampsia and diabetes. And also when there are serious concerns about whether the baby is growing well, whether the baby will be able to withstand the stress of labor, etc. Now, as we have been seeing over this last few minutes about CTG, which Dr. Chanchal explained so vividly, we know that CTG relies on pattern recognition, as she was talking about the W waveforms and the various others, shoulderings and etc. But we also know that not all CTG patterns are associated with intrapartum fetal hypoxia, and we don't know all of them. And what CTG I think is probably normal, the other person may actually turn out and say that no, there are decelerations here or the variability is not good. So there are a lot of inter-observer and intra-observer variations as well. CTG can pick up even slightest bit of problems. It has a good sensitivity. But to say that if a CTG is abnormal, the baby is bound to have problems is very difficult to say. So it has been found to have very poor specificity and poor positive predictive value for intrapartum hypoxic injury. That means that even if the CTGs are abnormal, it is not necessary that the fetus is having intrapartum problems and needs to be taken out immediately. For example, even if the CTG shows late decelerations, complicated baseline tachycardias, and complicated variable decelerations, the literature has shown that only 40 to 60% of these fetuses actually turn up and have intrapartum hypoxia. So we may be doing more cesareans than what are required. We may be panicking more often than what is actually required, just if we rely on CTG alone. Now, because CTG gives us, these high false positives, it's imperative that we also have certain other tests which can act as adjuncts and give us some kind of a, some kind of an idea whether the fetus which we are dealing with is actually in trouble or not. And these few adjunct tests are fetal ECG, then we have fetal blood sampling, and fetal pulse oximetry. Along with that, continuous CTG, as we were just talking, Dr. Shalvi was, I think, telling us about that she likes to use CTG every 4 hours and continuously in the second stage of labor. There are certain hospitals and certain obstetricians who like to use continuous CTG throughout in labor. So yes, continuous CTG is used, and these are the other adjuncts which I was just telling you about: the fetal ECG, fetal blood sampling, where the fetal blood sample is taken out through the fetal scalp, and fetal pulse oximetry, where there's a small electrode which is attached onto the fetal skull and which measures the oxygen saturation of the fetus. Now, do we need to do continuous CTG in all? Well, the literature is quite clear on that, and the guidelines clearly say that use of continuous CTG in low-risk women is not to be advocated, and it is controversial. However, again, if there are certain high-risk conditions in the mother, in the form of severe preeclampsia, diabetes, or there is fetal growth restriction, oligoamnios, or if there are abnormal Doppler changes, and the baby, the fetus is at high risk of hypoxia and acidosis, then of course continuous CTG is advocated. And when we are doing intermittent auscultation with a stethoscope, if we realize that there are certain abnormalities, then continuous CTG is definitely advocated. So these are the CTG classification. I will not be going into that. All this has already been dealt with. The same classification implies for continuous CTG as well. In fact, when I was just going through the literature search, I realized that there are abundant Cochrane reviews on CTGs. And there is one in 2017 where continuous CTG is being compared with intermittent auscultation, which we so often do in our labor rooms. And this Cochrane review, it said that if you use continuous CTG, the neonatal seizures are halved, but there is no difference in cerebral palsy rate. There is definitely a high increase in the cesarean rate with continuous CTG, and the women are also more likely to have instrumental vaginal delivery. But there is no difference in cord blood acidosis, and there is no improvement significantly in the perinatal death rate. So actually, even if we are doing so much and trying to take out continuous CTG recordings for our patients, we may actually not be able to benefit her much, because there is really no difference in the cerebral palsy rate or on the perinatal death rate. So how much we are actually benefiting, we do not know. And similarly, continuous CTG with intermittent CTG. This again has been studied in Cochrane 2017, and this also said that even if you are giving continuous CTG, there is no difference in cesarean rate or instrumental birth rate. In fact, this Cochrane review reported that there is less cord blood acidosis with intermittent CTG as compared to continuous CTG, which is a big surprise because this is a little strange. And the authors have also reported that this could be just by chance that intermittent CTG actually turns out and gives you better results as compared to continuous CTG. Now, a new technology has come for almost 2 decades now, especially in European countries and North America, which is STAN. STAN has been used very often in most of the obstetric units in these countries. And it basically stands for ST analyzer. When we say ST, we are actually talking about the ST segment of fetal ECG. And the idea behind it is that whenever there is an hypoxia during labor, it was going to lead to ECG abnormalities in the fetal circulation. And if those ECG abnormalities are looked at, we will be able to identify particularly those hypoxic babies which need delivery immediately. So just to very briefly explain about how this fetal ECG work, we know that this is the P wave, this is the QRS complex, and this is the ST segment, which is completely on the baseline, and this is the T wave. So this fetal ECG basically is a complete graphic record of what exactly the myocardial activity is happening in the fetal cells. And why this fetal ECG is chosen is, that's because if you look at the adjunct methods, especially the fetal blood sampling or the fetal pulse oximetry, here we are actually taking out the sample of blood from the peripheral tissues. Peripheral tissues may actually be having hypoxia, but the central organs may still be well oxygenated. So the idea is to identify those fetus whose central organs, namely the heart and the brain, are also deprived of oxygen. And that is why ECG is so very important as suggested, because ECG picks up the myocardial activity. So it also tells us about the oxygenation status of the myocardium. So because it's the central organ, so if myocardium is affected, so we understand that the brain will also be affected. And so it's an indirect evidence that the fetus is actually suffering from hypoxia and needs to be immediately looked at. Now, if we see this fetal ECG, there are a lot of waves, isn't it? But when you naturally, when the fetal heart rate is around 120, 140 beats per minute, so you're not going to exactly look at all the waves. It's not possible. So what exactly the fetal ECG records is just this ST segment, which is a straight line at the baseline, and the T waves. That is all the fetal ECG looks at. So what it actually does is, it analyzes this ST segment and T wave in relation to the QRS complex also. So it takes the amplitude of the T wave, it takes the amplitude of the QRS complex, and it finds out a ratio. All this is done electronically because it is just not possible to take a tracing of the fetal heart and then calculate it. So all these things are done by the computer software, and it tells you just exactly whether it is normal or abnormal, and that is what we need. So this ST analyzer, it basically identifies two kinds of fetus. It tells you whether this fetus is well perfused and does not, the labor and monitoring and everything can continue, or it tells you whether this fetus has exhausted all its oxygenation resources and is suffering from a hypoxia insult. So before it becomes too severe and the baby develops delayed milestones, this baby needs to be taken out immediately. So with this slide, we can see that this is the electrode. This electrode is applied onto the fetal scalp, and another electrode is applied onto the maternal thigh. Now, these two electrodes are important because sometimes it may happen that the fetal electrode is not really picking up the fetal ECG waves. So this maternal electrode, it basically helps to differentiate, and we know that the ECG waveforms which we are able to see or the computer is recording is actually fetal ECG electrode. So this is what the machine looks like. This is the ST analyzer. So this fetal electrode, when it is applied onto the fetal scalp through the vagina, we don't need another external monitor to detect the fetal heart. This electrode picks up both of them. So this is the kind of a picture which you get on the screen, where this is the heart tracing. These are the contractions. And now what we see below is exactly the fetal ECG. Now, if you see carefully, this is not really a fetal ECG recording which is coming. These are just crosses. So these crosses are basically by the computer software. So what it does is, when you apply this ECG electrode, the machine which is attached to it, it calculates the normal baseline T and QRS ratio. This is the T and the QRS complex ratio. So it just calculates that for around 4 to 5 minutes initially and sets itself that this is what is normal for this baby. And then subsequently, it analyzes 30 fetal ECG complexes and says whether everything is normal or not. And it just puts a cross on the monitor. If you have a fetal heartbeat of around 150 beats per minute, for 30 fetal ECG complexes, you get 1 cross. So for 150 beats per minute, you will get 5 crosses per minute. So this is what is evident here. If you see that this paper speed is 1 centimeter per minute, and we can see 5 crosses here. If the fetal ECG complexes are different from what the baseline was, that means this fetus is developing some kind of an hypoxia insult, and it will send an alarm. It will say that there is an ST event, or the TQRS complexes are shown as ratios. So it just tells you which ratio it is coming to. So exactly, we are not going to look at the fetal ECG tracings. All we are going to see is the crosses, and these crosses fall into the ratios, and it also marks whether there is an ST event, yes or no. So again, if we look at this tracing, this TQRS ratio, which I was telling you about, can sometimes be just episodic. That means it just goes up and then it comes down. Or it could be a baseline where the entire shift has occurred and the hypoxia is long lasting over 10 minutes. Now, why does this happen? If we just try and understand, it's actually not very complicated. What exactly is happening is, whenever there is some kind of a fetal, disturbance, you can say, there is a catecholamine surge, and this catecholamine surge, it actually leads to glycogenolysis. Now, because it goes into anaerobic metabolism, and this glycogenolysis, it causes the release of potassium ions. Now, this potassium ions become tall. So once the T waves become tall, the ratio is going to increase. So
Dr.
depending
Smriti,
upon...
Sorry to interrupt, 1 minute remaining.
All right. So this episodic rise can be sometimes seen because of fetal movements also, and baseline actually indicates hypoxia stress. So interpretation of STAN again comes in only two ways. It says either the ratio is high or there is an ST event. So depending upon what we get, we are going to start. Now, when should we start this STAN analysis? It is when the patient is already in the first stage of labor. It's not then when you start seeing CTG abnormality, you start STAN. That is because that then the fetus, which is already hypoxic, the STAN will not be able to differentiate when it becomes worse. So the fetus has to be normal before you actually start the STAN tracing. So this is how the reading is, where the ratio is taken, and you also look at the ST event. Now remember one thing, that if the CTG is very abnormal, it is pathological, then even if the ST analysis says everything is fine, you still need to deliver the baby. The problem is only when the CTG tracings are suspicious, that is when you need to know whether the fetus is actually hypoxic or not, and that is when STAN helps you. So this is a Cochrane review which was done in 2015 regarding the utility of STAN, and it said that though you have less neonatal encephalopathy, you have less fetal scalp samples, but there are similar cesarean rates and not really much difference in what exactly the outcome of the neonate. The STAN cannot be used in already hypoxic fetus because the machine is not going to take up further changes. It cannot be, it can be used only when the baby is term and not less than 36 weeks, because here the myocardium is not fully equipped. Intrauterine infections you cannot take. If the baby is in breech presentation, again, STAN will show you inverse findings. So a software has to be reset. If there is rapid fetal heart, you can't read the fetal ECGs well. Even the machine cannot read it. And if there are fetal cardiac abnormalities, the STAN is not going to help you. You compare the continuous CTG and STAN, the Lancet says that there is less operative delivery for fetal distress when STAN is used, so it may have some kind of a utility. Another study in 2019, it also said that operative vaginal delivery rates were less as compared with CTG alone. So to conclude, we know that STAN, there will be fewer babies with metabolic acidosis, there will be fewer babies with neonatal encephalopathy, fewer fetal scalp blood samples, fewer operative vaginal delivery, but there is no difference in cesarean section rate, no difference in perinatal deaths, and ICU admissions or blow-up cars. So in the end, the take-home message would be that even now, the NICE clinical guideline released in 2015 says that intermittent auscultation should be used in low-risk women, and only with abnormal findings should you proceed with continuous CTG. If there is pathological CTG or suspicious CTG, then you may need fetal scalp stimulation or fetal blood sampling to rule out metabolic acidosis. STAN can be used only as a substitute and not, it is not a substitute. It can be used as an adjunct to CTG, but as of now, it is not really recommended for routine use either by NICE, RCOG, SOGC, or Cochrane reviews. Thank you so much. I hope I have not exceeded my time.
No, Dr. Smriti, you are well in time. Thank you for a nice presentation. Your slides are very good. Now I will like to invite our next speaker, Dr. Nidhi Bedi, my dear friend. She is Associate Professor in Pediatrics and NICU in charge at Hamdard Hospital. She will be speaking on cord sampling and correlations. Dr. Nidhi.
Thank you, Dr. Nidhi. And I thank you, the whole team, for giving me this opportunity. And okay, I'll just like to start my screen sharing.
Yes.
Okay, just give me a second. Okay, so is it visible?
Yes.
Is the screen visible?
Yes, we can see you.
Okay, so after almost 3 hours run of CTG, a lot we have heard about cord sampling, blood gas analysis. So it's very important to know that why we are doing it, when to do it, how to do it, and what is to be interpreted, because that gives us a lot of information about the outcome of the baby. So my very first question goes to, why have we moved to umbilical cord blood gas sampling? We have been running with APGAR score for years together, and Dr. Virgin Apgar had very beautifully given us those 5 parameters. But where did the things go wrong? One, it is a very subjective method. If you ask 2 people to take out a APGAR score, we may find a difference. An APGAR score of 6 will call it as a moderate birth asphyxia, whereas a one with 7 will say it's a normal baby. So how do you differentiate? Second, this has a very low prognostic value when we talk about long-term complications. So many times you would have seen in your clinical practice that a baby with no history of birth asphyxia turns out to be cerebral palsy. How come? How is that possible? Again, if there are so much differences, if it is so subjective, then is it good for medical and medical? And the perinatal asphyxia which determines that the APGAR score, or there are other factors which can affect the APGAR score? What are the other factors? Any malformations may lead to a falsely low APGAR score, neuromuscular disorders, any fetal hemorrhagic shocks, or in fact, any drug intake by mother like magnesium sulfate or any anesthetic agents that may make the baby a little more passive. The movements may not be that good. So that will simply decrease the APGAR score. So there came the need for fetal blood gas sampling. And this is one of the most objective method of determining the metabolic condition of the baby at the time of birth. So now the question comes, when to do it? A big question, whether it should be done for all babies, whether it should be done for some selective cases. So previously, in 2006 and 2012, the American College of Obstetricians said that it has to be done in some limited cases, high-risk cases like where cesareans are done for fetal compromise, where APGAR score is coming low, there's severe IUGR, there's some kind of abnormal tracing, CTG is not working well, where there's some intrapartum fever where you are suspecting a sepsis-like condition outside. So they had formulated some areas, but in the same time, in contrast, another society is saying that it should be performed in all births because they don't want to miss any high-risk babies. So this came as a big query. But if we do in all, lot of problems, we need more people, we need more technicality, then they can be maybe over-judgmental results. So in finally 2014, both ACOG and American Academy of Pediatrics together decided to perform umbilical artery blood gas analysis wherever they are suspecting fetal metabolic abnormality. So where all to suspect? Wherever there are low APGAR scores, especially less than 3 at 5 minutes. Category 3 fetal heart rate patterns, all operative deliveries where there has been a non-reassuring fetal status, and any possible condition where we expect neonatal depression. So what are those possible conditions? There's a whole list. They include these, and there may be still many more. Some of them, which I can just point out here, are where we have MSL deliveries, where we have breech deliveries, where the baby is IUGR, where there's a uterine rupture, where there is abruption, where we have a preterm delivery, prolonged labor, any risk factors for sepsis, and so on. So there's a huge list beyond that. So now we have decided we want to get a umbilical gas done. How to do it? Very important that everybody should know it. It's not just the pediatrician, it's not just the gynecologist. Every team member who is there to perform the delivery and who is part of the delivery team should know it. Why? Because this is one step which will give a lot of help in diagnosis, treatment, and prognosis and outcome. So how to proceed? The first step is, as soon as the delivery is done, as soon as the baby is out, immediately without wasting any time, we have to clamp a segment of 10 to 20 centimeters. I'll just show you how it is clamped. Once we have clamped the segment, we have separated that segment, we can withdraw blood in a pre-heparinized range as we do for any blood gas. We withdraw the blood from where is preferred to take from umbilical artery. And as we know, there are 2 umbilical arteries and 1 umbilical vein. So I'll again show you how it is. So you can see in this small photograph, this little baby has 3 clamps on it. One is in the end, the big clamp, and 2 small clamps. So the area between the 2 clamps, this area, is one which has not been affected from anywhere. So a sample taken from this will always give you the correct results. Another method is we can put double clamps and we can just cut it in between. So this area will be totally cut off from rest of the body. So this part can be taken for any umbilical cord sampling. And if we follow the rules, artery is there, below that is the vein, and underlying again is the artery. So we always go at an angle which may be around 30 to 45 degrees. We never go perpendicular, because as we go perpendicular, you can see we are entering into the vein. So we prefer umbilical artery samples. Why? Because that gives us more of a fetal information rather than placental information. So again, if you see in this photograph, we can see there are two umbilical arteries and one umbilical vein. And here you can see a real time where this is umbilical artery and underlying is the vein. This is how a cord seems, and this is well known to all of us. So if I can play this video, I'll just see. So if you can see in this video, you can see the blood oozing out from one of them is the umbilical vein. This is the artery, this is the vein, and here is the artery. So this is the sequence that we saw in the other photograph as well. So upper is the artery, then is the vein, and here again is the artery. So again, if we see this second video, okay. So this is the segment which I'm talking about. This is the third clamp, second clamp, first clamp. This is the segment from where we can take the sample. It can be taken separately as a cut segment as well. If BB needs resuscitation, we can just cut it between the two clamps. If I again show you between from here, and we can take this cut segment separately so that the neonatal resuscitation is not hampered. So again, as I said, cord has to be clamped as soon as possible. Even a has been shown to have a lot of variation. So longer the delay, greater the changes. And how will we see the changes? Changes will be in the form of fall in pH and increase in PCO2. Many times this may not be pathological, this may be normal physiological. Why? Because of something called as hidden acidosis. And this is a transient physiological phenomenon which just happens so as to stimulate the baby to initiate his own self-breathing. So this finding may sometimes make us give us a false impression that there is some acidosis, and we may worry. But again, it is not the case. So we should not delay the sample. If we have decided to take umbilical blood gas, we should take it immediately without any delay. Otherwise, we can be over judgmental, as I said in the starting. To discuss again, sampling of umbilical artery blood is preferred than vein. Why? Because umbilical artery reflects mainly the fetal metabolism, whereas as we know, the venous blood, which gets the oxygenated blood in from the mother, it reflects more of placental functions. In case we have any discrepancies, some of the clinicians prefer to take a paired sample so that it can be cross-examined with each other. And another important thing is it should be processed at the earliest. And it has been seen that once it is done within 20 minutes, it has been found not much of a difference is there, but even up till 60 minutes, results have been much comparable. But the best is to do it within first 20 minutes. As we know, venous blood has oxygenated blood and arterial has deoxygenated in these cases. In umbilical arteries, so the pH of the venous blood is little higher than the arterial blood. So that will actually help us to differentiate the things. And if we see in a paired sample, there's a difference of 0.09 on an average between the artery and vein. So again, to specify arterial pH and base deficit is at this point of time the most will give us the most accurate information upon the fetal acid-base status and has a direct correlation with newborn morbidity. But it is not just the arterial pH, it is now a combination of arterial pH and the base deficit. Why? Again, I'll explain upon how to interpret upon what we have got. Once we have the umbilical artery pH, it can only tell us whether there is acidosis or there is no acidosis. Now, if there is acidosis, what next? Next, we have to see the base deficit. Why? because this helps us to define whether it is a respiratory acidosis or metabolic acidosis. But why is this important to us? Because the outcome with a respiratory acidosis has formed to be very good, whereas a metabolic acidosis has been associated with a much higher increase of neonatal morbidity or mortality. So any umbilical arteries, only respiratory acidosis, you can stay assured or reassured or little reconfirmed that things will not get complicated. But once it is a metabolic acidosis, then there is a possibility of going into a neonatal worsening, which may include seizures and conditions like cerebral palsy. So what is normal and what is abnormal? These are the reference values which I just wanted to share, because we generally don't have these values. These are not the same as any arterial blood gas values. So for umbilical arteries, for a term baby, an average pH is between 7.27, PCO2 around 50, and bicarb around 22, and base excess around 2.7. Whereas in a preterm, there are minor changes, which is like pH is little higher, 7.28, and roughly base excess is around 2.5. So we have found, or studies over the time have shown, that as the pH decreases, the chances of neonatal asphyxia increases. But there has to be some cutoff which has to be considered when we start planning treatment. So it has been seen, if I talk about pH of 7.2, it has a very high sensitivity to detect neonatal asphyxia. But again, the specificity is low. But if I talk about 7, it has a very high specificity, but then it tends to miss out cases, thereby giving a low sensitivity. So now what is the correct pH at which we should act? The correct pH has been taken variably between 7 to 7.2. And as I'll discuss in a while, what has been the guidelines which have come to it. So this was all about pH. Now talking about base deficit, yes, it has a direct linear relationship with neonatal morbidity. And because more the base deficit, more the lactic acid accumulation, and more the neonatal morbidity. So they even found a base deficit of 12 to 16 associated with almost 60 to 70% of neonatal encephalopathy and dysfunction. So taking again the cutoff, it has been on an average accepted to be more than 12 millimoles per liter, which is more than 2 standard deviations. So the guidelines, though these were 2003 guidelines, I'll move to the 2014 guidelines, which are the latest, which are as per the neonatal encephalopathy and cerebral task force, in accordance with both ACOG and AAP, who have come to a conclusion that intrapartum asphyxia is defined by presence of fetal metabolic acidosis at birth in the umbilical artery sample. And how to define fetal metabolic acidosis? If the pH of umbilical arterial cord blood is less than 7 and the base deficit is more than 12 millimoles, we define it as intrapartum asphyxia, and thereby we move ahead with all the management as per any neonatal asphyxia, and we manage for HIE. Thank you.
Thank you, Dr. Nidhi. You are well in time, in fact, before time.
Thank you.
There are a few questions from the chat box. First for you,
Yes.
Dr. Nidhi. Is this how many cord blood samples after taking a trainee will become an expert in taking cord blood samples?
As we all say, see one, do one, teach one. So by the third, you will be trained. It does not require too much of expertise, but yes, it has to be learned once and taught once.
Okay, fine. Thank you. Next question is for Dr. Smriti. Is there any role of computerized CTG? Ma'am, kindly unmute yourself. Yeah, is there any role of computerized CTG in telemedicine during this COVID era?
Yes, of course, there is a scope of telemetry. Telemetry has come a lot in the developed nations, where the patient can just tie that CTG belt and roam around. It doesn't even need to be wired to the machine, and everything is recorded onto the computer. And I think, yes, the time has come. We need to have computerized CTG. And when we say computerized CTG, we basically mean that there is a computer software which is actually picking up all the abnormalities. But as the previous lectures also said, that we should not be treating the CTG alone. We should actually be looking at the patient as a whole. But yes, the era of computerized CTG, I think, has definitely come.
Okay, what is the cost effectiveness of using this computerized CTG?
So computerized CTG, cost effectiveness, See, computerized CTG cannot be used like that just by itself, because the computerized CTG will be beneficial only if somebody is actually, is actually interpreting the CTG, and the computer is interpreting the CTG on its behalf. But well, I think I really don't think, I'm not sure about the cost effectiveness, but again, the patient has to be taken as a whole. Can't just look at the CTG and come.
I think the main issue about computerization of the CTG is that it has not been found to be very superior as yet. In future, it might, but up till now, the conventional CTG and the computerized CTG have not really shown any significant difference. And of course, there's a huge cost differential, huge. So therefore, I'm not sure about the cost. I must tell you that. Also, I must confess that I think nobody here has seen a computerized CTG. It's all book. So that is something that everybody must know. But the cost benefit ratios have probably not worked out. So therefore, don't forget that the most number of papers on computerized CTG are from the European nations. And they are not so cost effectiveness and conscious about that, because mostly it is discovered from Scandinavia. But I think that that's one of the main loopholes why it hasn't become so popular. Can I, Nidhi, ask a question to Nidhi Bedi, please?
Yes, ma'am. Yes, you can ask.
Nidhi, you didn't talk about fetal lactate evaluation in the cord blood evaluation. So would you like to comment on that, please?
Ma'am, can you come again upon the lactate you said, na?
Yes.
Okay, ma'am, as far as lactate is concerned, it is not a very good marker. Basically, lactate can vary because of the way it is checked, and because of some parameters in the body, lactate can be giving a false value. In fact, up to 6, it may be considered normal in a cord blood gas. So it has not been found to have a very good correlation with the neonatal outcomes. So we don't prefer lactate as the screening when we discuss about neonatal asphyxia, in correlation.
So the point is that if your pH is also not so significant and the lactate is also not so significant, then should we be talking mainly about the base deficit?
No, ma'am. If the pH is also not significant and lactate is also not significant, we expect even base deficit to not go beyond 12, because generally it correlates with the pH. And even if we see the guidelines, they consider both pH and base deficit together. So if the pH
so that means it's not one in isolation.
No, ma'am.
So that is the important message I think that we must give our audience, that it's not only a question of the pH, but we tend as, I think, clinicians to focus more on the pH because that's something we are more, relevant to us. It makes sense. And the base deficit has to be calculated, and it possibly makes a little bit less sense to us. But I think this message must go down the line that it is the importance of both and not one in isolation, because most people talk in terms only of pH.
Dr. Nidhi, even I have one small question that we often hear pediatricians tell us that we should do delayed cord clamping. In fact, some now even suggest that we do milking of cord blood. So how do we do the cord blood gas analysis if we do that?
If we talk about delayed cord clamping, first of all, if we have considered as to take out umbilical blood gas sample, we are thinking that this child probably will need some amount of resuscitation or is a high risk. In any high risk cases, delayed cord clamping is not preferred. It is when we are considering a normal delivery where everything is okay, there we are happy with delayed cord clamping. But in case we are doing a delayed cord clamping and we still wish to take an umbilical sample there, we can take it from the unclamped cord immediately after delivery. It has been found to be equally good as when we do it. I mean, once till you are planning to clamp, just immediately after birth, take a sample, and it has been found to be almost in correlation with other samples that we take. But the point is that if we are suspecting a high risk, then and we are suspecting some resuscitation, then we don't wait for delayed cord clamping.
Dr. Nidhi, can I ask you a question, please?
Sure, ma'am.
I wanted to know what about, ECF, chord pH and base excess? I mean, how does it, because nowadays they say that, it is more accurate if you calculate in the extracellular fluid. What do you have to say to that? I think you need a different ABG machine for that, isn't it?
Exactly, ma'am. That is a different ABG machine, and it is not really too much in. I mean, it's not very commonly being used as of now everywhere. But some of the studies have shown it to be a little better, having a little better correlation. But frankly, I really don't know how much difference it is going to make. But yes, some studies have shown a difference where they have found it to be more in correlation with the neonatal aspects here.
Thank you so much.
ऐसा लग रहा है कि सारे
extracellular fluid
definition को पकड़ लिया.
I would be curious to know how to collect a sample of the extracellular fluid.
Ma'am, वो उसी में ही separate करते हैं. We take the arterial sample only, and from there the machine takes out the ECF from the blood itself. Understand, because it is done, the sample is the same. The sample is from the umbilical artery and the umbilical vein only.
So it is the plasma which we are testing, labeling it as
Yes.
Okay.
So question answers are over. Should we start our panel discussion?
I think that shows the confrontation between the obstetricians and pediatricians, because the maximum number of questions were for Nidhi. Is that so?
Yes,
exactly. But I think the difference of perception may be a better terminology to use.
Yes, ma'am. That was better. Thank you so much, ma'am.
Thank you, Dr. Nidhi. Thank you, Dr. Nidhi.
Thank you.
Now we will start our panel discussion, for which I will like to invite Dr. Aruna Nigam and Dr. Arpita Dey. Dr. Aruna Nigam is professor and unit head at Hamdard Institute. It is not possible to sum up her achievement in such a short time. She has established endoscopy at this institute. She has numerous publications and launched a mobile app and a website to educate UG and PG students. Our next moderator for panel is Dr. Arpita Dey. She is assistant professor at Hamdard Institute. She is specialized in urogynecology. Now over to Dr. Aruna and Dr. Arpita for case-based panel discussion.
Okay, thank you, Dr. Nidhi. Okay, let me share my screen first. Share. Am I visible? My screen visible?
Yes, ma'am, your screen is visible. Just put it on slideshow. Yes, ma'am, it's visible.
Okay. First is, I would like to ask just all the viewers to click the screenshot, although you are getting the mail from the AOGD office, to fill up this Google form, which contains 15 MCQs. And it's not to test your knowledge, it is for our testing that whether we have given any knowledge to you all, right? So please do this for us so that we can judge ourselves by this. And you can fill it till tomorrow. After tomorrow, it will be switched off, right? So coming to the panel discussion on CTG analysis, having such a vibrant lectures from all our speakers, I think there is nothing to say, but it is just a request from my all panelists to be calm and cool, so that जो obstetrician का होता नहीं है कि इसने इसकी गर्दन उसने उसकी गर्दन पकड़ी, ऐसा नहीं, सब one by one. So let's have my panelists with us, Dr. Rinku, Dr. Neha, Dr. Jayashree, Dr. Shakun, and Dr. Bindya.
Hi.
Hi. So Dr. Rinku, she's a faculty in CTG training workshops in various AOGD and NARCHI conferences, and she has been shortlisted as one of the nominees in reducing cesarean section in private sector, a BMJ Award 2015. She is a co-investigator in several maternity care related ICMR projects. Dr. Neha Gupta, she is associate professor with us at Hamdard Institute of Medical Sciences and Research, and she has numerous number of awards. I think there are too many, I'm not going to read at all, and she's a very vibrant person and a beautiful also. Coming to Dr. Shekun Tyagi, she's associate professor at Maulana Azad Medical College, and she has a lot of experience in high-risk pregnancy, and she has received many awards like International FIGO Fellowship in 2019. She has also got a Best Paper Prize in FOXY in 2014. So over to you, Dr. Arpita, can you introduce?
So next we have Dr. Bindia Jhan. She's a consultant at NMC Royal Hospital, UAE. And Dr. Jayashree Sundar, she's senior consultant at Rainbow Hospital with special interest in high-risk pregnancy.
So before starting, I just want to say ये webinar में आजकल हो क्या रहा है? हम बोलते रहते हैं स्क्रीन को देखकर बोल रहे हैं तो what I thought just now कि there is a less somatic activity like baby जब distress हो जाता है तो कोई acceleration नहीं है. दूसरा क्या होता है कोई sympathetic stimulation नहीं है, अच्छी साड़ियां नहीं देखने को मिल रही, बातें करने को नहीं मिल रही. So there is a bradycardia also. So now I am trying with this panel discussion. I'm just trying because I have not conducted panel discussion on the webinar. So I'm just trying to do a intra-webinar resuscitation so as to involve you all. So just to start with mind-blowing questions, and I'll request my all panelists to give their views as much as possible, whether we are able to complete our all questions or not. Although very beautifully, Dr. Chanchal has covered many questions, but still that is a one perception. Now we will have a views of all our 5 panelists, what is to be done in that situation. So CTG, it is a most common investigation done in labor, can be very helpful in high-risk pregnancies if correlated and interpreted wisely, as Dr. Chanchal, Dr. Aisha, Dr. Shalini did. But it is overutilized, less evaluated, over-abused investigation responsible for increasing the cesarean section rates. Invent of CCTG is a revolution in the management, but is still not available in India. We will be following ACOG guidelines, FIGO guidelines, or NICE guidelines, which you people are following at your centers. We are acceptable to all the guidelines. I'll start with Dr. Jayashree, and if anyone wants to add, kindly do so after the first person comments. Kindly give your opinion one by one and keep your mic unmuted and face visible. So just to start with case 1, Dr. Arpita.
Yes, this question is for Dr. Jayashree. So we have 32-year-old, gravida 3, para 2, live 2, 39 weeks of pregnancy, and she came with labor pains. She's a known case of hypothyroidism controlled on thyroxine. Vitals were stable, per abdomen, it was term, cephalic presentation, 4/5 was palpable, good fetal heart 140, mild contractions were present, and she was 3 centimeters, 60% effaced, vertex -3, and pelvis adequate. So the first question that we have is, does she need an admission CTG? Dr. Jayashree.
Yes, though this patient is a low-risk pregnancy, definitely I would do an admission CTG for her, just to reassure that all things are okay, because CTG does give an interpretation that the baby is happy inside. So I would do an admission CTG for her.
The next question, what are the indications of CTG monitoring? If you're thinking of monitoring this patient, what are the indications?
So I said I'll do an first admission or a CTG of 20 minutes, and I would not be doing a continuous monitoring on this patient because she does not need any continuous monitoring, and she should be allowed to be going in spontaneous labor and with intermittent auscultation, and there should be no intervention on this patient because she's already contracting on her own. She might be in early labor and she would spontaneously progress. She does not need a continuous CTG at all.
Okay, I would like to have an opinion of other panelists also, that whether we should be going for an admission CTG in this case, one by one. And if we can start with Dr. Bindia, will you like to go for a admission CTG?
See, I have a few more questions to ask over here, which is, it hasn't mentioned whether she's in labor. Is she contracting? And technically speaking, according to the Royal College guidelines and NICE guidelines, it is still a high risk because she's hypothyroidism. She's on, she's taking Altoxin.
She's
also
controlled. She's controlled.
Yeah, even if she's well controlled, but she does have a medical disorder here. It's not a situation, I'm sure you must have involved the endocrinologist and a multidisciplinary team input. So I would go for it. Also, based on my experience, there have been lots of cases of fetal-maternal hemorrhage. And CTG is one very good tool where if there is any abnormality that we pick up on CTG, it would be a good idea to keep on records. And I have been working in the UK where we are very well supported medico-legally whenever there are any medico-legal implications in situations like this. Having moved to the UAE, we would do admission CTG because technically it is classed as a high-risk pregnancy.
Okay, Dr. Shakun, will you like to go for it? Dr. Shakun?
There is no evidence which supports that doing admission CTG in a low risk patient improves the outcome. In low risk patient, we at our setup are not doing admission CTGs. We are reserving this only for high risk patients.
Right. Okay, so if we are sitting up in a good corporate hospital or in UK, we will do it. Otherwise, in a government hospital, we can escape it. But as such, I think guideline still says that no need for intrapartum continuous CTG. Next question.
So as I was asking, what are the indications of continuous CTG, Dr. Jayashree?
So if so this patient as of now doesn't need a continuous CTG, I would put a patient on a continuous CTG only when I'm going to do any augmentation with syntocin on drip, or if my patient has taken epidural in labor, or if I feel that there is a distress, she has got meconium stain, grade 2 meconium staining of the liquor or something of that sort, then I would, or if there is any medical condition, like she is, we know that it is a very IUGR baby which is in labor. So these are the conditions where I would put her on continuous CTG, but for regular on this patient, definitely no continuous CTG.
Exactly. So we considered her as a low risk because she was euthyroid, but next, we see that CTG was done by the resident. So next question is for Dr. Shakun. Can you interpret the CTG?
We don't have the name and the date, still we go ahead. First of all, contractions. Marking, there we can see only 2 contractions here. So there must be around 1 or 2 contractions only in 10 minutes. She's not contracting very vigorously. Coming to the trace, we start with baseline. So a 2 minutes trace, which is not showing any acceleration or so, the baseline is around about 150 per minute here. And variability is good, more than 5 beats per minute, less than 25 beats per minute. There are accelerations present, and I could not see any deceleration. So it is good enough, and we'll continue with the observation for this patient.
What other information would you like to see? Like you talked about the patient's name. What other things would you ask for confirming before looking at the CTG pattern?
Pulse rate. I also want to know the pulse rate of the mother. Yes. Is very important apart from this. Any drugs she's on, vitals of the patient, any epidural she's got, and definitely the paper speed.
Right. So there is a difference of opinion regarding the baseline. So in this, if we take a 2 minute, you could say there is a baseline, or maybe we could say that there is no baseline in this. And if we do not have a baseline, then it becomes very difficult to comment on the accelerations, decelerations, or the variability, because you need baseline for
.1 minute to a 2 minute trace where there's no acceleration or a deceleration, and you see whether it is ranging between 110 to 160. Now, this patch of CTG that you have shown me, I would say it's more like a wandering baseline.
Yes.
You could say the baseline is 140 and there's an acceleration to it. Equally, you could say that the baseline is 160 and there's a deceleration to it. The other thing is we are not seeing any uterine contractions. The previous strip of CTG that was shown, I could not appreciate any uterine contractions. But given that the variability is good, I wouldn't be very worried about this trace.
Okay. So how do you take, what are the criteria of taking the baseline? Just
So anything between 110 to 160 is taken as a normal baseline. Then you have non-reassuring baseline could be anything between 100 to 109. Or on the other hand, it could be a tachycardic baseline, which is, you can say 161 to 180. More than 180, it becomes abnormal, and less than 99, you can say it becomes abnormal on the extremes of spectrum.
Okay, so if you say it as a wandering baseline, what will you advise to your resident?
Okay, so I need to see the previous CTG. This is just a patch you've given me. I would like to see what is her baseline CTG. Where did we start, in other words? And are we're talking of the same patient, right? Hypothyroid.
Same patient, and you have got resident Aya. Resident has said, this is a wandering baseline, madam. What has to be done now? Or your sister said.
Okay, so maternal pulse rate is fine.
Yeah, fine.
Okay, no temperature, no sign of infection, nothing.
Yeah.
I would just observe. I'd say just keep an eye, review it in 20 minutes, get a fresh eye look also. So we tend to, what we do is, we tend to get another person involved to give their point of view as well. I would just observe. I tell my registrar, please observe this.
Okay. So when baseline is not there, can you comment on acceleration, decelerations?
No, not really. As I said, I would say the same thing. If baseline 140, then you have an acceleration. So we tend to watch these kind of traces.
Okay. So what should be the normal speed of CTG machine which you are using at your place?
It's a standard, the box standard, 1 centimeter per minute.
Okay, right. So that is the standard, and we should be using that, or whatever speed we are using, we should have a habit of seeing those strips only.
Exactly.
Otherwise, if we start seeing the 3 centimeter after 1 centimeter, it looked like to be a bradycardia or a cheese bill.
Exactly. Yeah.
So next question, Dr. Rinku. A 30-year-old G2A1 at 37 weeks of gestation, she is a diagnosed case of FGR and oligohydramnios. On ultrasound, parameters were corresponding to 32 weeks, effective fetal weight was 1.8 kg, and umbilical artery PI is normal. So on examination, she was around 32 to 34 weeks. Cephalic, effective fetal weight was around 2 kg, and on examination, per vaginal examination, os was closed and uneffaced. So she was a high risk, so we got a CTG done. This is the CTG trace. Can you please interpret it for us?
So I can see 2 traces here. Can you tell me?
This is one trace. I have just taken out those names and time.
Okay, so so this patient's trace is the one which is shown above?
Yeah, yes. This is a contraction. Lower one is a contraction. You can see.
Achha, this is a contraction trace.
This is actually, she was not contracting. She was not contracting. This is.
Okay. Right. So, so first of all, I would like to know, even in fact, in the previous patient also, I would like to know how many movements she's been having in the last few hours. Like, is this patient giving you a history of reduced fetal movements? Because that will be very, very critical.
Okay, this patient is not complaining of any decreased fetal movements.
On specific questioning.
Yeah.
So that is very important because she has a background of growth restriction. And I understand that the CTG is running for around maybe 20 minutes, 15 minutes?
15, 20 minutes around.
15 minutes. So obviously there's a reduced baseline variability, and you can see the baseline, which is about 140. And if mother says that she's been having very good fetal movements even an hour back, and she has no history of reduced fetal movements, I'm going to carry the CTG on for a while, because the most important feature that we have to look for is cyclicity. Cyclicity means if you have a phase like, a stable baseline phase where there is no variability or very minimal variability, and then you start seeing accelerations again. So supposing this trace is for 20 minutes, I would like to make it go on for 10 minutes more, at least wait for an hour, half an hour. In half an hour, if the CTG continues like this, then I need to think. Because if this mother is having good fetal movements till now, and beyond 30 minutes, she's having a trace of this sleeping pattern with no cyclicity, I would like to get an ultrasound biophysical done for her. That would be my first step.
Okay. So that means the most important point is we must be asking a leading question of fetal movements if we have not asked.
Yes.
right?
And she's not in labor. Yeah.
If patient is not in labor. And second thing, we should be continuing with the CTG.
Yes, yes.
Okay. So we continued for 40 minutes. And what are the causes of reduced variability in general?
Yeah, so reduced variability could be just physiological. You know, the baby has 3 phases. One is a deep sleep phase where there is a reduced variability. Then there is an active sleep phase where you see cyclicity, some accelerations, and then active wakefulness, something like the CTG we saw just before. So supposing there is a reduced variability, we can safely continue for some time. But if this reduced variability phase continues for more than 30 to 40 minutes, then we need to think whether there is a problem, because sometimes reduced variabilities are associated with pathological conditions like fetal-maternal hemorrhage, fetal anemia, etc., even chorioamnionitis. But most of the time, this, you know, if you give sedation, for instance, or, you know, you give certain drugs like betamethasone, you could have phases of reduced variability, which could be just as fine. But like I said, you have to look at the underlying cause. Supposing you are suspecting there is a baby, there's a mother who's come with reduced fetal movements, or there is a acute bleeding episode, you have to think of other causes like, you know, some cerebral hypoxia. So you have to look at the entire clinical picture before you know, make any conclusion regarding that.
Okay. So, Dr. Shakun, if this patient would have been preterm, like less than 32 weeks, will your opinion change?
Baseline variability is absent in this case. Okay, and the main changes with regards to rate and autonomic activity usually does come by around 32 weeks. So it is the reduction in autonomic activity, reduced autonomic activity could be because we can't just give up that this is not hypoxic. Okay. But so we must see for a longer trace as was seen. Okay.
Okay. So can you explain the effect of steroids and magnesium sulfate on the fetal heart rate?
Definitely, both steroids, magnesium sulfate lead to reduced baseline variability. So if the patient has had, this patient has had corticosteroids or Maxulf, it could be reduced because of that.
I just want to ask, in the ACOG, they have written fetal heart rate variability is affected by betamethasone, not dexamethasone. And nowadays we are using a dexa. What is your experience?
Actually, in India, we should be giving only dexamethasone because the betamethasone, which actually is advised by the international standard, is not available in India. So basically, DEXA should be given here, and we are using mainly DEXA only.
So then there will be no effect on fetal heart rate variability. I just wanted to know your experience, because for last 6 months to 1 year, we have started with the dexamethasone. Before that, we were using a betamethasone. So अभी भी ये चलेगा क्या?
Betamethasone, this could be, I don't know, this might not be because of the drug itself if you have given betamethasone.
Okay, Dr. Rinku, do you
have you mean to say that reduced variability is because of
yes. Yeah. I'm just asking in general because we know that betamethasone has a decreased variability effect. But nowadays we have started using DEXA. We are not using beta. So what is in your setup that are we having a decreased variability with the DEXA also?
We have not witnessed any reduced variability, and we've always used dexamethasone. Okay.
Can I add to this?
We take decisions based on one 20-minute trace in this patient. The trace needs to be extended further. Okay, we can't. Okay, this is definitely the variability is reduced, and snapshot. We can't make a decision that if the weight at what is the weight of this baby? Like earlier, the weight was okay.
Yes, we are coming. We are showing you
We need to
further CTGs. Dr. Bindya, do you
So-
want to add something?
Yeah, see, Aruna, I've had the experience of using betamethasone in the UK for years and years. And we did notice, of course, a decreased variability. Now, being here for 4 years, dexamethasone also causes decreased variability.
Okay.
So it's, although according to the Royal College guidelines, beta is meant to be better. But for certain reasons, we are using Dexa. But I would say fetal heart rate variability does decrease and the effect stays for good 24 to 48 hours. And this preterm 32 weeks, sorry?
That's what I wanted to know, because ACOG guideline says that DEXA doesn't have effect, but we are finding that it is having effect.
It is definitely having it. And because I've been auditing the data here and also speaking to my senior colleagues in Cornish Hospital, which is the center of obstetric here, they have the same experience.
Okay. So the next question is for Dr. Shakun. You can see this trace. And if the patient would have been in spontaneous active labor, can we do anything to check the status of the fetus? We have a baseline, we have low variability, we are thinking.
What is the period gestation now?
Term.
We are talking about the
term
original
size,
case.
active phase of labor, she is in 6 centimeters.
Okay, she's the same 1.8.
Yes,
Actually, we have slightly given the situation so that we can cover many things.
So
but
I would like to see the high risk factors in this patient.
37 weeks, fetal growth restriction with oligohydramnios, umbilical PI was raised at 2.33, clinical and ultrasound baby weight was between 1.8 and 2 kilograms. So we had an initial trace, which is this one. And now, do you want to do anything to actually confirm the status of the baby? Do we have any?
If patient is in active labor.
Yeah, she's 6 centimeters. Are the membranes present or membranes are
absent?
Absent. What is the color of Leica?
Clear.
Was scalp stimulation done along with the pervaginal examination?
So that is what you would like to do.
That's what you would like to do. Scalp stimulation. How we do a scalp stimulation, madam?
So while doing pervaginal examination, the CTG is already there, and we try and stimulate the scalp with a finger for about and see the response for increase in the heart rate during the stimulation.
So what we do, we scratch. Just for the audience, what we
our fingers are gloved, so we don't use the nails. We use we rub it with the fingers. Like that's what we have been doing. We've had thesis also in our department, scalp stimulation test with the palmar part of the finger, the ventral aspect of the finger is rubbed over the scalp for a certain duration and see for the response, whether the tactile stimulation causes the acceleration or not.
So how long we do like this on the fetal head? 10 seconds, 15 seconds or 2 seconds?
No, at least 30 seconds to 60 seconds we try and do it.
Okay, so that is very important point according to Dr. Shakun. If you are doing a scalp stimulation, you will be doing with the pulp of the finger and doing a rubbing over the fetal head, and it should be for 30 to 60 seconds, right? That is what you want to communicate, Dr. Shakun?
Yes, sure.
Okay, thank you so much.
So what happened to the baby?
We are continuing, ma'am. It's not yet over.
Yeah.
Dr. Rinku, this is for you. So this patient of growth restriction, we induced with 3 gels. Per abdomen, just a recapitulation, 32 weeks. Moderate contractions have started coming. So interpret the CTG and what can be done next.
So did her CTG, was her CTG better in between? Because that's very important, because you started with a CTG which...
Yes. So basically we had started with low variability, but after 40-45 minutes, the CTG had come out to be normal with a variability. And
so it never became reassuring in between.
No accelerations were there. No acceleration was there. Baseline.
Yeah, but the variability was also that low, and then after that the CTG became like this. Is that what I understand?
The in between CTG,
Variability
their
had-
variability was
had
there,
come back.
but accelerations were not there. We induced with 3 gel. After 3rd gel, moderate to good contractions started coming, and the CTG showed these findings.
Yeah, so what I understand is that the prior CTG was fine.
Yeah.
And
Yes.
now this CTG is showing a suspicious pattern.
Yes.
So the baseline is clear. It is a determinable baseline. It is somewhere around maybe 146 or something. And the variability is fair enough. It's about around 5 beats, I would say. But you're seeing these decelerations, and
Right.
these decelerations are, they have a slow fall. I wouldn't say they are rapidly falling and picking up. They have a kind of a U shape there. And can I see it, in relation to the contractions?
Yes.
So in relation to the contractions, I feel they're coming with the contractions. They're more, type 1 in nature. That means they're picking up when the contraction is over. So this is a baby who has a background of IUGR, otherwise having good fetal movements. Prior CTG was normal. And definitely this CTG needs to be watched, because I will not say that this baby is not compensating. There could be an element of hypoxia happening, but this baby is still compensating, because number one is that the baseline is well maintained. The variability, I don't know. I'm assuming that the previous variability was fine. So this one is also around 4 to 5 beats. I would like to watch for a while, but I'm going to keep my eyes on the strip continuously. And I feel the contractions are too frequent. I mean, I'm not happy up there. There are probably, what I can make out, around 4 to 5 contractions in 10 minutes. So she's had 3 gels, isn't it?
Yes.
Can I wash off the last gel? If possible, I'd like to wash it off. Or I would also like to give her, while I'm watching her, I'd like to give her something to reduce her contractions, like a glycerin trinitrate sublingual.
Okay.
I wouldn't mind doing that while I'm watching her, but I'm going to keep her prepared provisionally for CS with the background of IUGR. That's what I'm going to do.
Okay. So is this W-shaped?
No, not really. See, W shape is also something controversial. I mean, these days they say that biphasic decelerations are atypical, but by itself, a W shaped is not something which is important. There is some element of variability in each decelerations. I wouldn't say that the decelerations don't have variability, which is a good thing. Okay. And the other good thing is that the baseline is picking up. It is not shooting up or falling. After the deceleration, the baseline is coming up to the same level, which means the baby is compensating. The baby is coming back out of the water, like Dr. Chanchal says, drowning and picking up again. Right. But the thing is that these decelerations are not deceleration. See, again, whenever we talk about decelerations, we always should talk about decelerations in more than 50% contractions. Yes. And we should talk about decelerations for a while. In a strip of 10-15 minutes, 5-10 minutes, we shouldn't be talking. But then, of course, I understand that this is a case of IUGR also. Yeah. So there could be an evolving hypoxia. Evolving hypoxia is what I'm talking about. It is not an acute. Sorry.
So evolving hypoxia was there.
Yeah.
Humne kya kara, what we did.
So we did a pervaginal examination. She was 5 centimeters, 70% effaced. Artificial rupture of membranes showed that she had thick meconium, grade 2 meconium. So even though you are right that we could have waited, but keeping the background in mind that she was growth restricted with oligohydramnios, and it was basically a chronic placentopathy or a chronic problem was there. So maybe the capacity for the baby to take an acute insult would be very low. So we had taken the decision for cesarean, and we delivered a 1.8 kg baby with a good Apgar score. But had it been any other patient, yes, we could have waited for a longer time to look at how the decelerations go further.
So yeah, maybe the MSL took you towards cesarean section, which is absolutely fair.
High risk factors, the intrapartum meconium and the continuous deceleration.
So all panelists agree with our management?
Absolutely. Yeah. In fact, I had concerns at that time. Variable decelerations were there with concerns, and for more than 50% of the trace. So yeah, absolutely. I would have gone for the same decision.
Okay, chaliye, first case passed. right?
Yes, please.
So, Dr. Bindya, this was a case of post-dated pregnancy. 41 weeks, we generally take till 41 weeks. So we have induced after 41 weeks with 3 PGA2 gel. There were no high-risk factor. And within 3 hours of last gel, the patient started complaining of constant pain in the abdomen. On examination, vitals were stable. Abdomen, term size, cephalic, good frequent uterine contractions, and fetal heart rate was within 140 to 150 per minute. And os was closed. This was a CTG. Can you please interpret for us?
Yeah, so I also use the Dr. C. Bravado technique. The risk here is she's post-dated. Induction of labor becomes another risk factor for post-dating. So now coming to my baseline. So I always get these wandering baselines. I would take the baseline would be somewhere at 130. With a good variability, I can see the accelerations, some decelerations, and the contractions are 1, 2, 3 to 4. Remind me, she's a primary gravida, right?
Yes,
Yes.
Yeah. Okay, so I would say there are variable decelerations, but there's variability maintained. So I would still watch this trace. I would call it a normal trace right now.
Can you tell me about the contractions?
See, yeah, because she's a primary gravida, and if she's not having any pains in between her contractions, we do go up to 1, 2, 3, 4 contractions, even up to 5 contractions in a primary gravida is okay. I'm not thinking, maybe at the back of my head, maybe I'm thinking, what if she's abrupting? But I wouldn't act on it right now.
Kindly elaborate on these decelerations.
So I would call them more like, because there's variation too, I would call them more like a variable deceleration.
Okay. Dr. Neha, would you like to comment anything regarding decelerations?
Yes, they seem to be V-shaped decelerations. They are abrupt. There are abrupt fall and then pick up. They seem to be like variable decelerations. But in this trace, which I can see, nearly in a 10 minutes time, there are 5 contractions. So from that perspective, patient is having tachysystole, and that's what I would feel.
Okay, so there are 5 contractions in 10 minutes. So how do we calculate, Dr. Bindya, this Montevideo units? In this, can you calculate it for us?
So the kilopascals, we don't tend to rely on this.
Okay.
But yeah, general consensus with the CTG and the pressure and the kilopascals, we never rely on it because the patient may be contracting, but at the same time, she may have a movement as well. But what we tend to do is the old-fashioned technique. You should ideally be putting your hand at the fundus of the uterus and record the intensity, mild, moderate, or severe. But here I can see there's a relaxation between the so-called uterine activity. And by what my previous colleague said about tachysystole, you could argue tachysystole, but according to the NICE guidelines, in a primary gravida, up till 5 can still be classed as normal.
Dr. Rinku, do you want to comment on it?
See, if this patient had the prior CTG was normal, I wouldn't worry too much about these decelerations. One, her baseline is fine, her variability is good, but she's having these variable decelerations, which are, I would say, quite typical in nature. You could see some shoulders, and right now, whether these hyperstimulation is causing this or not is difficult to say. I wouldn't really call this a hyperstimulation. I think there are 4 to 5 contractions in 10 minutes.
Okay.
So anyway, intrauterine pressure is not seen by the CTG. We just see the number of contractions, I think, by a visual CTG. That's all we can make out. It's not the intensity. The intensity is only by hand.
Yeah, that's very right. But just to
why is she having continuous pain? First of all, patient is complaining of continuous pain.
Yes.
and all the contractions, there's a certain deceleration is there. So even if we can't, and other thing is she's 41 weeks, she's going towards post-date.
Okay.
So
Okay, is she
there could be
41?
an
I forgot
evidence
that.
of placental insufficiency. So we can't take her as completely low risk patient. So we have to keep an eye on her. And what is a pervaginal examination?
देखते हैं, चलिए. So this. So just in between, we'll finish off our questions which we have kept. What is the difference between tachysystole and hyperstimulation, Dr. Neha?
Tachysystole is basically when 5 or more contractions are coming in a 10 minutes span of time. When these contractions are causing an effect on the fetal heart rate, as in any changes, then it becomes a hyperstimulation.
डॉक्टर अर्पिता भी पीवी कर रही हैं, बता रही हैं डॉक्टर शकुन आपको. Why do you think this change has happened, Dr. Neha?
It could be because of the induction which we have done. Maybe the cervigel has been over enthusiastically instilled inside the os by the resident doctor, and that could be one of the causes. And the high risk being 41+1, maybe I would like, and patient complaining of persistent pain. I would like to re-examine per abdomen and per vaginum and see what is to be done.
So we thought of hyperstimulation in this.
Maybe even washing off the gel if I felt that there is some kind of a hyperstimulation.
Basically, this is what had happened. After 2 gels, there were no contractions, and the resident, obviously with all the enthusiasm, had put a speculum to pit the gel properly, and it must have got inside the internal os, leading to hyperstimulation. We did think of it because she was constantly complaining of pain. So what do you think we can do in such cases, Dr.
I think
Neha?
Dr. Neha has covered this thing. No?
Sorry, can I just ask another thing? Even if the patient is she complaining of constant pain in between the contractions as well?
Yes, so that is where we had started looking at the toco as well, and we took a tracing.
So we've got abruption at the back of our mind, basically.
Yeah, that's very relevant.
We had checked that the pulse BP was normal, and we were thinking more in terms of overstimulation with the gel.
Dr. Arpita,
May I comment for a minute, Aruna?
Ji, ma'am.
I just want to say that one other important thing that could be thought about is that we're talking about tachysystole and hyperstimulation and other things. What about the sudden onset of the change of the contractions? I think that is an important thing because up till now, there were almost no contractions.
Yes,
and suddenly after the installation of that third CP, there is this problem. So this is not a question of the tachysystole that we know about as routine, as spontaneous kind of a thing. So this certainly, this abrupt change, I think this is another message that we need to give. That the abrupt change needs to be noticed and a cause kind of put to it, that why it has suddenly how she's contracting so much. So that is important to think about rather than to try and differentiate whether it's tachysystole or hyperstimulation. That itself gives an indicator that it's likely to be that.
That means we have to compare with the previous situation. What madam wants to say, that we have to see the previous situation always, whether it is a CTG or a condition of the patient.
Yes. Absolutely. So we did wash out the gel because we thought it is the gel which is causing the problem, and we positioned the patient, and this is the trace that we got after 45 minutes.
So Dr. Jayashree, can you tell us?
So when I look at this CTG after that, I can see our baseline was at around 140 per minute before. And in the same patient, I know the risk factor is 41 weeks. When I'm looking at the contractions, now I cannot make out how the contractions are. And is it a persistent hypertonicity of the uterus? That's what I feel that is being recorded on this monitor. So I would like to put my hand on the patient to see what is the tone of the uterus. Is there any relaxation in between? And I can definitely see a shift in the baseline of this patient. So we were at a baseline of around 140, but I can see that the baseline has almost moved up to 170 near about, if I'm not wrong. And it's gradually going up the baseline. So this this will keep me worried, because any baseline shift, but two things is there are no accelerations per se, though the variability is reasonably okay, and there are no decelerations also, but definitely there is a baseline shift in this patient of it has moved above the 160 mark to 170. So I would keep a close watch on this patient.
That means compensatory mechanism has taken place and
the patient, the baby is going into fetal tachycardia now.
So what is more important, the fetal tachycardia or the comparative change that you have told? That it is basically the comparative change that we are having a sudden shift from 140 to 180 beats per
So that
minute.
means अगर 110 से 140 50 हो जाता है, तो that is important, or it is 150 to 170 हो जाए.
I would give more importance. Any shift of baseline will have its own importance in the patient, but definitely if it is going above 160, I would give much more importance to it, because obviously this is the first mechanism of compensation by the baby, which is going to be acidotic. So we will have to deliver this baby sooner and keep a close watch on this fetal heart rate. But obviously till 180, if the variability is good, we are not very worried. But this baby, this is a non-reassuring. This is not a totally normal CTG for me.
Yes. So basically we started all the resuscitative measures, keeping that in mind that we had decelerations going on to tachycardia. We did plan a cesarean. So after an hour, there was some improvement, but the fetal tachycardia remained.
So I think we all know the causes of fetal tachycardia. Dr. Jayashree, will you like to elaborate, or?
So the one thing is, if there is a maternal dehydration, that should always be taken into consideration. I have seen when patients are in labor and they are not hydrating well, many people don't keep a watch on their intake output also. They don't drink enough, they are not hydrating enough. So that I have seen many times has led to fetal tachycardia in many of our patients. Giving them an epidural also hypertension, which causes the fetal tachycardia and the shift in the maternal in the rate. And obviously other causes, the rarer ones are if there is any abruption which is increasing the fetal tachycardia. But first, obviously, the temperature of the mother, the pulse rate, her hydration, these are the three common things we should look for. And obviously we should rule out infections and other factors. But in this patient, I would think about dehydration also in this patient, and also hyperstimulation.
Very good. Right. So, Dr. Neha, what features one should observe in tachycardia tracing?
In the tachycardia, we should specifically look at that time whether there are any accelerations which are still present. What is the variability within that that trace, and whether it is well maintained or not, and whether there are any associated decelerations. If they are repeatedly happening, if they're not repeatedly happening, then we are reasonably assured that it should be fairly okay.
Okay.
But without the accelerations, without the beat to beat variability, it will become something which we really need to worry and monitor.
Go slightly fast because only one case has been so far.
This is the tracing that we got. 180 से ये 150 तक आ गया, and we thought that हालांकि tachycardia के बाद a decrease in baseline may be a little bit alarming, but the PV was good. She was around 8 centimeter. She delivered in 3 hours. The Apgar was 588 and could be resuscitated, and within a day the baby was handed over to the mother.
I will add one point here. I would do a cord pH on this baby, because it is just not the Apgar which matters, as we heard our pediatrician speaking. Because for documentation, I would like to have a cord pH done on this baby.
Absolutely.
Did we find any retroplacental clots and all?
कुछ नहीं मिला, Dr.
Yeah. Okay.
Now coming to the next case, a 35-year-old primey with infertility treated at 38 weeks comes in labor. She had IHCP with bile acids raised. Vital stable, term size cephalic, fetal heart was regular, 3.3 kg. She was in active labor, 6 centimeters, 70% efface, vertex at -2, and membranes were present. And this was the CTG. Dr. Shakun, can you comment on the CTG? Toko is not there.
Okay, so baseline, I can't talk about there are high risk factors. She has IHCP and she's infertility treated. So she's a precious pregnancy. We have to take care of that. We don't have contractions. but the rate is, baseline is around almost just going slightly above 150 here.
So what?
There are decelerations. We cannot type the decelerations without a TOCO. That's the importance of TOCO. And present here. The whole of the trace is not seen. It could be because of the TOCO probe, the FHR probe getting detached or not. And this deceleration, which could be a deceleration, is prolonged. And there are other dips also, going to about almost 30 beats per minute here also. So I would be very, she's already 6 centimeters. And with clear Leica.
So no,
Yeah.
membranes were
Membranes
present.
present hai.
So ARM, because I don't have a okay. Leica is
the next PV finding that we found.
Further decelerations associated with the contractions during the contraction, after the contraction.
At that time, that probe was not put. So,
but later on, when we have observed, we can't get this patient.
Yeah, that probe should have been put, but we don't have that.
Leica was clear.
Okay.
Is a cesarean required at this stage where there are decelerations coming down, dropping down, and they're significant? So, do you think with 8 centimeters Leica clear, she needs a cesarean?
No, CTGs don't tell us about whether cesarean needs to be done or not.
Absolutely.
We have to see whether the trace is suspicious, abnormal, or normal. So this is not normal. Okay. And to classify it as abnormal, we need to classify the decelerations, which we feel are the deceleration, which can't be classified without the contractions. Okay, if they are late decelerations. So late decelerations, we would like this will become a normal CTG, going towards a normal CTG. So definitely she would require intrauterine resuscitation.
Yeah, because contractions were quite high. That's why we don't have a TOCO probe, but the contractions were high. So what all can be done for intrapartum fetal resuscitation?
So first of all, we should not give oxygen by mask, which is usually the trend. First, we want any we would like to put oxygen because it causes free radical generation and further injury. But if the patient is dehydrated or hypotension, then IV fluids can be given or position can be changed. So that usually require. And if the contractions are too frequent, then only we need to go terbutaline 0.5 to 0.25 milligram can be given.
Yeah, that is very important point regarding oxygen and fluid therapy, because we all have a tendency for oxygen fluid therapy. Are most of the patient in labor room, but generally are dehydrated because 24 hours they are not having anything. So we should be weighing this thing that whether they are dehydrated or not. If they are dehydrated, of course, we should be giving fluid therapy. But otherwise, as such, fluid therapy has a deleterious effect. Why? Because it causes an electrolyte imbalance, and that is more harmful for the neonate, which we deliver. So after 30 minutes.
So Dr. Jayashree, we have this trace after around 45 minutes when we had the decelerations that we see here. So now at this stage, what can you comment on the deceleration that we are seeing?
So this deceleration is pretty prolonged. So I have to, this is almost, if I'm not wrong, around, there is a recovery, but there is a deceleration. I will do a PV again. I would like to deliver her sooner than later. She is already 8 centimeter. So I would check for her per vaginal finding and prepare her for delivery. And I'll have to keep things ready for delivery. So irrespective of where I deliver her, I will follow the 3, 6, 9, and 12-minute rule out here. And she needs to be delivered by 9 minutes. That's for sure.
So can we have the rule just for recapitulation?
So when you do it within 3 minutes, we have to call the team and start the maternal resuscitation. That is the intrapartum resuscitation. 3 to 6 minutes, we should have a cause for this prolonged bradycardia. If needed, use of tocolytics and also fluids to be infused. If it is going to be touching 9 minutes, she should be shifted to the place where she needs to be delivered, either normally or cesarean section, which should be in theater. This should not be conducted in the labor room. And if it's more than 9 to 12 minutes, obviously, then this patient definitely needs a delivery, because we know the pH drops by 0.01 per minute. So we are going to look at a baby with a very low pH. So if we are going to cross 12 minutes, we have already come down in the pH very heavily. So this baby needs delivery by 12 minutes. There might be the odd patient or the mother who after 9 minutes it might improve, but then also we should be very judicious in our approach. And since there is already an intrapartum insult there, so we should not be prolonging or changing realistically the decision for delivery in such scenarios, and this mother definitely needs a delivery.
So we did a cesarean section and we have a slightly poor Apgar score and the baby needed a bag and mask ventilation finally. Now,
again,
did you find a cause for this acute hypoxia, Dr. Aruna? Cause of the hypoxia?
No, we could not find anything.
Why was there a raise in baseline in the contraction? The uterine pressure is increased suddenly. You can see, was it?
No, there was no abruption or any of the acute causes.
No cord prolapse or anything.
Cord prolapse or
no running oxytocin.
No,
must be cord compression only then.
Yeah.
But actually, keeping
the
in
uterine
mind,
pressure is increased suddenly after this, and it continues to be
something
based.
has happened, and keeping in mind the high risk factors regarding the patient, 35-year infertility.
She was infertility treated, maybe.
So 35-year-old primary gravida with IHCP and bile acids 40. So
yeah,
at 9 centimeter vertex at 0, it was a long time that we were looking at. So we couldn't even apply forceps at that time. The decelerations were coming on and they were not stopping. So we took her up for a cesarean.
Can I just add a point here? I know it's all. See, any person who is delivering a baby is a precious baby. So this concept of just because they have been fertility treated, would you have done anything different for a mother who has conceived herself on this patient? So if the bradycardia is happening, irrespective of whether she was infertile or fertile, in labor, I think we will treat them the same. And that should be the take-home message for all patients. We give undue importance to the fertility treatment and confuse the management, I feel.
All the babies are precious.
But they usually have underlying other morbidities.
IHCP was also there.
Many of the time, infertility patients have other underlying morbidities also, which we might not be taking into take. So especially there are higher chances. We have seen there are always higher chances of complication in patients who have had treatment for infertility. And she was 35 years old, primary gravida.
वो VIP syndrome का भी चक्कर हो जाता है ना?
Exactly.
So we did this. We did this. So, Dr. Bindya, if this would have been previous section, what will you suspect with this deceleration?
I would have definitely suspected a scar dehiscence at this stage.
Definitely.
There's no arguing about it. In fact, maybe earlier.
Yeah. And what are the other important conditions which we should suspect with this type of deceleration in a laboring patient?
In a laboring patient, so see, this is a acute, it's an abnormal feature according to the criteria. So are we looking at a cord prolapse? Are we looking, obviously, scar dehiscence we've mentioned. Then there's a abruption, sudden abruption can always happen. And if the membranes have been ruptured and you get bleeding, what have you ended up with a vasa previa?
Yeah, definitely. So we must be careful with these type of deceleration. So just
can I add, in scar rupture or in abruption, usually tachycardia should have preceded the bradycardia, and maternal pulse also we have to keep a track, because it is very unlikely that suddenly it is going to dip.
Right.
Yeah, I think each of the traces should have a maternal pulse.
Actually,
yes, that's very important. Maternal pulse is very important.
कुछ हमने पैनलिस्ट के पूछने के लिए रख दिया कि पल्स रेट पूछें आप, टेम्परेचर पूछें आप हमसे.
So
See,
that
abruption is something, obviously, it will not happen suddenly. If the patient says acute pain and then you get this, then you're going to think it's an abruption.
Yeah, we should not be.
And bleeding is very important as well.
We should be diagnosing the patients.
alarm you. That means it should alarm you.
It should alarm bell should go.
अगर resident देख रहा है तो आपको phone करे. Management should be immediate. In these type of deceleration, we cannot wait for so long.
Yeah.
As already Dr. Jayashree has explained regarding the pH. So important points regarding deceleration, we all know we have to see type of deceleration, duration, late return to baseline, associated non-reassuring features, presence or absence of shoulders, variability with accelerations, and always consider the patient in toto. So coming to the next case, do we continue? We have 2-3 cases more.
It's very interesting. Why not?
Okay.
So this question is
we'll go hurriedly.
This is for Dr. Rinku, 30-year-old primary gravida. She was unbooked, came in active labor, term size cephalic, head was well engaged, but head not palpable. 7 centimeter, 90% effaced, vertex 0, and Leica was clear. So this is the pattern that we are seeing. Can we have the interpretation?
Okay, she's 7 centimeters and she's a primary gravida.
Yeah, primary gravida.
And okay, so maternal pulse, I suppose, is fine.
Yeah,
and there is a baseline tachycardia of around 180 is what I can see.
Right.
And the variability is about, okay, 4-5 beats per minute, not too bad. And then there are these decelerations, which are variable in nature. Now, this baby probably has element of pre-existing hypoxia. We don't have a, sorry, have we moved back to the previous trace? Can I go back to the one that I was seeing? Hello? Yeah, so we don't have any pre-existing trace for her. I'm assuming that previously she's not complaining of any loss of fetal movements or anything which is, you know, significant. So her pre-existing hypoxia probably is associated with the labor element only.
Yeah.
So now when I look at this trace, I have to first see, you know, how long she will take to deliver. If I think, you know, with my PV finding that I can, you know, in a couple of hours she will deliver, I could wait for a while to see what is happening next.
Okay.
Because overall the CTG is suspicious, still not abnormal, but I would have to look at the entire picture and keep her provisionally ready for CS, looking at the next strip and seeing what happens.
Dr. Rinku, is this W shape it?
Yes, you can call it a W shape, but calling it any shape does not matter.
Does not matter.
What we have to remember is that is this baby, see, the most important thing is to see whether this baby is decompensated or not. Now, this is the first trace that I'm seeing. There is a baseline that I can see, but it is tachycardia, isn't it? Now, this is the next trace. Have we moved
9
on?
centimeter, good progress, vertex S +1,
Okay.
45 minutes later.
Okay.
So, और आपने क्या किया डॉक्टर रिंकू, आपने ओवर दे दिया डॉक्टर शकुन को. अब
Okay.
डॉक्टर शकुन संभालेंगे.
Okay, okay.
So, Dr.
So
Shakun,
now this lady is having, you know, she's having a lot of contractions. I can see very frequent contractions here. Okay. I'm not too happy with the contractions, and the CTG has kind of, I would say it's kind of worsened. You know, now it has started swinging up and down. It's kind of swinging up and down. And there is a intermediate, you know, time where it is slightly better, but I'm not very happy with the decelerations, which are showing very less variability. Now I want to deliver this patient fast.
Fast.
She's
So,
9 centimeters, vertex at +1.
OT ready. Now what? 20 minutes later. Cervix fully dilated, vertex at +1, patient pushing. क्या करें?
So instrumental delivery, of course. I'm not at all happy with this trace. This baby can come out hypoxic because I don't know what her trace was before she was 7 centimeters. How baby was doing before that.
There is a lot of loss of contact also in this trace.
There is, which is very common in the second stage, which is very common. It's very difficult to get a proper trace in the second stage.
Yeah.
And like here, the baseline is not very clear. The heartbeat is swinging up and down. It is probably showing some kind of autonomic instability.
And there's total loss of
Although in
variability.
second stage, these kind of abnormal patterns are common. I know they happen sometimes. But why I'm worried about this baby particularly is because I don't have any trace before 7 centimeters. I'm just looking at the story of this last 1 hour. So
now
this baby could come out bad.
When we applied headed +2, we applied forceps.
Right.
And then baby delivered 2.8 kg, Apgar 445 as you predicted, cord blood pH 6.66. Grade 2 HIW.
Should we go like see the previous traces, and could we have differed and made certain different decision?
Yes.
It
hardly takes.
How long do we have? It's a trace of 1.5 hours, I believe, or how long is it?
1.5 hours, hardly.
Yeah. So
do you guys
I don't know.
sorry
Doing
to
a
interrupt.
cesarean would not have made a difference.
Aruna, do you all
Maybe
have
not.
fetal blood sampling facility in India?
Blood sampling is
yes, of course.
No, fetal blood sampling.
No, we don't do that.
No,
here.
cord is after the baby is delivered. So because if this situation is posed to us, we would have, as you correctly said, the first time when you see a suspicious trace, not knowing what happened before the fetal blood sampling would have been very, very handy to see whether we can wait and watch or we need to deliver immediately.
Actually, Dr. Bindia, it's not available at every place in our scenarios. So we have not available.
Aruna, can I come in?
Yes, ma'am.
See, this CTG was abnormal CTG at the start. There was fetal tachycardia, there were decelerations, right?
Yes.
So this baby should have been delivered within half an hour to 60 minutes. We took 1.5 hours to deliver the baby, and the pH at 6.6 would have definitely changed. I beg to disagree because the pH would have been 7.1 maybe when she came into the hospital, irrespective of what CTG we had before. Right, but definitely that CTG, our medico-legally or clinically, we would have been correct to deliver her 1.5 hours before and not wait for 1.5 hours. As I said in the previous question, that the pH drops 0.01 per minute, right? So we waited too long on this baby to deliver this baby, though she was progressing pretty well. But the initial CTG was an abnormal CTG, and the take-home message should be she should have been delivered within 30 minutes of that CTG.
Yeah, definitely, I agree, because now we are assessing retrospectively.
So retrospectively, it is, yes, retrospectively, I fully agree.
Were abnormal, both the
yes,
as well as the
and this is not a case of acute hypoxia. Actually, it started with probably a pre-existing hypoxia, and then the baby became more hypoxic as labor went on.
Yeah.
Isn't it? So definitely retrospectively you feel, but it all depends, Sometimes you think that this mother will deliver in half an hour.
So good progress, 7 centimeter, 9 centimeter full +2. What else we want? So you see these heart rates, was it a maternal pulse or doubling of the fetal heart rate?
Yes.
It could be there.
Sorry?
It's very likely that it was a doubling.
Doubling of fetal heart rate or a maternal heart rate? That CTG machine must...
Maternal pulse not show variability.
Yes. Yeah, that's right. Though then it must be a doubling of the fetal heart rate. It must be around 90. Or I don't...
So that is also another problem. It may many times. So that's why, we should have a maternal trace continuously. Sometimes for these patients, we keep a maternal monitor continuously.
So how to differentiate between a maternal pulse and fetal heart rate in late stage of labor?
Dr. Neha?
Dr. Neha?
Yeah, so basically a maternal pulse, either by a pulse oximeter or by manually counting it, or some places you have a maternal pulse trace also, which is there. So this is very important because in the in the second stage of labor, it is very difficult to have there is a lot of loss of contact, which very often happens. And a lot of times either the maternal pulse is being shown, or if there is bradycardia, then that is doubled and shown in the trace, which we sometimes may misinterpret. So keeping a track of what exactly is the maternal pulse rate is important. Moreover, the maternal contractions will not show beat to beat variability or variability, which usually in the fetal trace would be there.
Very right, Dr. Neha. So we are.
And with the contraction, with every contraction, the fetal heart rate should actually dip, or there should be a deceleration. Whereas when it is the contrary if there is a false representation.
Yeah, actually AOGD office is ringing up, so we are taking up our last case, right? So it is a 28-year African primary gravida with 38 weeks of POG, presented with decreased fetal movement since night. On examination, vitals were normal, term size, cephalic, like appeared to be increased. She was having a good tone, effective fetal weight around 3.5 kg, os was closed, and ST was advised in a casualty as it is being done, and she was having decreased fetal movement also. So an ST was done. This all has been done by a postgraduate in a casualty. So we got this. Dr. Rinku, can you?
Yes. Hello. Yeah.
Yes, you're audible, ma'am.
So this is a lady who has no significant high risk history, as I assume. She's an African national in labor, is it?
Not in labor. She came with the decreased fetal movement.
Okay, she's come with decreased fetal movements. Okay, right. So this is a CTG which is not a happy CTG with a history of decreased fetal movements. I would call it kind of a sinusoidal pattern. I mean, I would call it a slightly pseudo-sinusoidal, if I may say so.
Right.
But with the background of decreased fetal movements, I would like to do a biophysical ultrasound for her straight away. And this is a mother who could be having a feto-maternal hemorrhage or some kind of fetal anemia if this kind of CTG continues for long.
Okay. So
next. What other relevant history examination would you want, and what is the differential diagnosis for such a pattern that we see?
Yeah, so I mean, we could do a KB test for the mother, yeah, to look for feto-maternal hemorrhage. And of course, like even abruption can give this kind of a picture. But of course, doing a proper clinical examination, following it up with ultrasound, and then deciding for delivery will be the right way forward.
Dr. Shakun, after 1 hour without admission, she was not ready for admission.
Okay.
Abdomen was examined by Dr. Arpita. Tense, mildly tender abdomen, fetal heart rate was present, PV may os close, uneffaced, and this was a CTG.
So I see her uterine, the uterine trace shows a rise in baseline.
Right.
So there is increased tone, and then there is fallen baseline above. So most like this showing that she's having a feto-maternal hemorrhage. Most abruption, which is causing the anemia, and the sinusoidal. It's so obvious.
तो लॉक कर दिया जाए मतलब ठीक है so she could be operated after 2 hours 30 minutes somehow she was not ready for admission and cesarean, so major abruption was there with a huge retroplacental cord of 500 cc, and the baby succumbed after 3 days. Bad outcome. So Dr. Neha, can you elaborate on sinusoidal and pseudosinusoidal? This is the last case. Dr. Neha? Dr. Jayashree, can you do this?
So, so when we see a sinusoidal pattern, it is more a smooth wave, and the cycle frequency you have already put up is 3 to 5 per minute, and it is usually due to fetal anemia, feto-maternal hemorrhage. Recently, I had a patient who had a very high MCA Doppler who had this sinusoidal pattern of CTG when we took her up. But if it is pseudosinusoidal, the margins, it may be more jagged, and there might be accelerations in between, and it usually settles down within 30 to 40 minutes. And usually then you have to look at the history of whether she has had any sedatives, and sometimes the pseudosinusoidal pattern could be because of suckling movements of the baby also. So we should be able to differentiate between sinusoidal and pseudosinusoidal, but a sinusoidal pattern with a history of less fetal movement, I think it is very classical for something, a fetal anemia, I would say, and most probably the tense feeling that you had was because of an abrupt hydrops or a abruption. So, so that is how we should be able to differentiate between the two.
Thank you, Dr. Jayashree. Now, this is the last one, just to complete the list of our sinusoidal, pseudosinusoidal. Dr. Neha, can you comment on this? I think Dr. Bindia? Dr. Bindia?
Yeah, so what are the risk factors here?
I'm just
just a random. So see, variability seems, see, baseline is, it's there can be two things here. Either the excessive variability of more than 25, number one. Number two, it could also be a lot of interference with the, you know, like some people used, like with the CTG machines, there's another electronic in the room that can also lead to these variations.
Yeah. So it is a saltatory pattern, and this is also alarming if it is continuing for long. So, and generally we get in the second stage of labor. So this was the last slide, and just to whatever we could gather with this all panel and lecture since afternoon, that whenever we are seeing some CTG, we should be considering three things: gestational age, high risk factor, and whether it is intrapartum or antepartum. Then when we have decided that it is an antepartum or intrapartum, see for the baseline, variability, and deceleration. If the patient is in active labor, go for and variability is less, go for a scalp stimulation. That is a ready available test with all of us. And if there are deceleration present, and especially if we are in second stage, differentiate between the maternal pulse and fetal heart rate. And whenever facility is available, please go for a cord blood pH so as to interpret intrapartum hypoxia and save your neck. So to final slide, I thank all the panelists who have given such a good input, and it is, I think, according to myself, it was a good panel with the help of all of you. So for all the audience who are still available with us, CTG is there to guide us. Patient's condition and clinical judgment are the most important point which should be considered for a final decisions. Good neonatal and anesthesia support are essential. So whenever you are taking this patient, any high risk factor or any patient, please inform your anesthetist and the technician, pediatrician beforehand. You need to have a good pediatric backup with you whenever we are dealing with the obstetrics. So thank you all for your patient hearing, and
thank
you,
you,
Aruna.
Dr.
Thank you so much, Aruna, Dr. Arpita, and all the team of.
Thank you, Reva ma'am, Dr. Aruna, Dr.
Nice to
Arpita.
see everybody again.
Can we have one?
Thank you.
All please just put your cameras on so that we can have one screenshot. And I am thankful to all our faculty, to AOGD, to our residents, and all our patients whom CTG we have utilized to discuss and improvise our knowledge, and to Dr. Eva, who has given me opportunity to be a co-convener with her. We really learn a lot from her.
Thank you, Dr. Eva ma'am. Thank you, Dr. Aruna, Arpita.
Can we have a screenshot? Please smile, everybody. One cheese during Corona.
Thank you. It was wonderful to have all of you here.
Bye-bye.
Thank you.
Thanks.
you.
Thanks,
Thank you.
Aruna. Take care.
Yes.
Bye. Bye, everyone.
Thanks.
Stay safe.
We request all our audience to please fill up that Google form. And all the audience also we thank at the end. There were 401 viewers. So thank you all. Bye. Best wishes.